Good morning, everyone, and welcome to our 5th High Degree Research Symposium. Due to COVID, obviously, this is the first one we've ever done as a Zoom meeting, but still we'll try and follow the same sort of format as we normally do. I would like to acknowledge the tradition of custodianship and the law of the country on which the University of Sydney campuses all stand. We pay our respects to those who've cared and continue to care for country. And where most of the campus is in the Gadigal lands of the Aurora Nation. So basically, I'm going to pretend I'm at ARVO. I've got an ARVO t-shirt on. I've just put on my sunglasses. You can see I've got a nice beach sunrise as my backdrop. And because basically this is as close as we're all going to get to a research meeting and ARVO, I think, in 2020. So we're doing this for the same reason that we all go to ARVO. It's a way that we can all find out what everyone's doing. It's a way that we can share our knowledge. It's not meant to be confrontational. It's meant to just be a good, relaxed sort of dialogue where we get to tell everyone what sort of work we've been doing and what our plans are for the future of our research. Rather than getting ribbons as we do at ARVO, we've managed to extract some money from the university. So there are prizes for the best presentations. But basically, I think the important thing is just to relax and enjoy the morning and listen to what everyone's doing. So without further ado, I will hand over to Jingjing, who's going to be the moderator for today. Thank you. I'll just unshare my screen.
Thank you very much, Peter. So hello everyone, I'm Jingjing. I'm honored to be given this opportunity to moderate this year's HDR Symposium. It is online now, but hopefully we are all familiar with Zoom setting by now. I would like to emphasize some housekeeping rules for audience and presenters. Firstly, for presenters, you have strictly 5 minutes for your presentation, and you'll be muted by one of our hosts if we run over time. The Q&A session is 2 minutes. Panelists are welcome to ask questions directly. For audience, please submit your questions on the Q&A channel in the webinar. Please do not share your screen until the presenter before you has finished their Q&A. You can start sharing your screen when I introduce your name and your presentation topic. If you have any questions during the event that are not directly related to presentations, please send private messages via the chat channel to our hosts, Emma, Janet, and Pauline. Let's welcome Stephanie Wiley to give us a talk on student welfare, which is particularly important in this current environment. Thank you. Over to you, Stephanie.
Sorry, I don't think I can, it's not letting me start my video, but that's okay. I don't need to be on video. I'll just share my screen quickly. Okay. Thanks, Jingjing, for the introduction. So as she mentioned, I work for student support services. So my role in particular focuses on international students, but we do a lot of work for students around Orientation Week and Welcome Week generally, and do a lot of advocacy for student support services. And as Jingjing mentioned, during this time in particular, it's really important to know what is available to you as students. The first thing that I'd like to bring to your attention is the COVID-19 advice page. Things can change rapidly in this environment, and the university is ensuring that all information that's been coming as updates from the government and advice and information from the university is in one place for you. So we have a COVID-19 advice page. It has everything from study information, campus operations. If you're an international student, there's information about visas and travel information, and also health management. So I'd really recommend that if you do have a question that you think something might be different than BAU because of COVID, this would be your first point of contact, because there's a large frequently asked questions section. There's lots of questions coming through, and we're sort of popping them all up on the website for you. So all of the support and services that I'll mention today can be found on the Current Students website. So if you go to the main University of Sydney webpage, in the banner at the top, there's a section for current students. If you click on that, it will take you to the page on the right of this screen, and you can see there that support and services is highlighted in a red box. So everything that I talk about today, you can find on our website. So there's sort of something for everyone, and you may not necessarily need a service now, but you may need it in the future. You may be able to refer a friend to it. I'd just like to reiterate that all of these services are free for our students, and they're all confidential. So we're not going to be telling anyone if you have used any of these services. And if you are not able to join us on campus, they've also moved online, whether that's through Zoom, online workshops, or online resources. Everything that we offer can now be accessed during this online sort of learning environment. So there's just a few that I'd like to speak to particularly. So our Career Centre are amazing. They do so much work in helping students connect with the area of career that they're wanting to go to through internship fairs and graduate job fairs. They also have an amazing Career Hub job database where they get an advertisement from recruitment external to the university, as well as jobs within the university. They have one-to-one career consultants and career skills workshops, and all of these resources can be accessed online as well. So they're a really great department to start engaging with in regards to your career. Our disability services team can help to provide services and adjustments to students that have both long-term but also temporary conditions or illnesses. So it could be something that you are living with throughout your life, or it could be something that's temporary and as simple as breaking your arm or your leg, and you need some sort of adjustments and extra support to be able to perform in your studies. You do need to register with them online, and it does require supporting documentation, but I recommend having a look at the website because it does go through everything in more detail. So obviously during this time, mental health is something that is popping up, and it's gladly and like it's becoming less of a stigma, and I think that it's amazing. And there's a few resources at the university that you can access. I know that myself, I haven't been feeling 100% all the time, and it's probably the first time in my life that I can say that my mental health hasn't been perfect and 100%. So firstly, we have our counselling and psychological services, otherwise known as CAPS. So they, as I mentioned, they are free and confidential, and they have individual one-to-one counselling with a clinical psychologist who are trained and expertise in succeeding in your studies. CAPS also have a great resources online. So there's self-directed resources and workshops that are offered throughout semester. And obviously you can go and see them on campus normally, but we're not doing in-person sessions, so everything's moved online. They are sort of within normal work hours, but anything outside of that, you can contact the mental wellbeing line for 24/7 support. So their number's also listed here. Following on from that, the university is actually partnered with Batir, and they're actually aiming to encourage, educate and empower students to speak about mental health issues and to smash the stigma surrounding that. They had a welcome event just recently, and I logged in and attended, and it was such a nice environment that they were creating to speak about mental health, and the students were really eager to participate and communicating and asking questions. So they have a Being Heard program, and you can also join as a volunteer. They've also hosting some activities and events throughout the semester, so you can connect with them on their Facebook group. So it's Batir UCID, and everything that they're doing throughout semester around mental health and creating a mentally health space while we're studying online. Everything will be posted on their Facebook throughout semester. So I'd recommend engaging with them, because even if you yourself aren't experiencing something with your mental health, you may know someone who is, and it's always good to know what resources that you can direct them to. Lastly, sorry, not lastly, but next, financial support services. So this is part of my team. And so we can provide financial support to students who might be struggling during this time. So we offer bursaries for eligible students, and we've actually opened that up to international students now. So bursaries are to help with sort of everyday living costs, meeting your daily needs in times of hardship. And we also provide interest-free loans. So those you do need to pay back, but there are no interest occurred on those. You can apply for both of these online via Sydney Student, but more information can be found on the website there. And I just want to note that this is completely separate to scholarships. So I'm not talking scholarships here, it's just financial support to help you with your sort of everyday living needs. I also want to make reference to the student charter, and this is something that if you are not already familiar with, you should be as a student. It does explain the university's expectations of you, but also what you should be able to expect from the university, and it reflects all of the university's values. So it's really important to understand your rights and responsibilities, so you know how you should be treated while you're a student with us. And if anything is outside of those values and you think that this isn't right, this shouldn't be how it is, we do have a student affairs team to look after those sort of complaints, which can be anonymous. So you can submit those to our student affairs team. The website's on this page. But I think it's really important to understand that this is something that you should know, because it is helping to create an amazing university environment for every student. On top of that, we've got our Safer Communities office, where our student liaison officers work. So they are the first point of contact for students who may experience sexual assault, harassment, domestic violence, and/or bullying, and they provide case management and advocacy. Obviously, it's completely confidential. They're extremely lovely staff, and they're there to sort of help any students that have experienced any type of harassment, assault. They've got an online reporting portal, so you don't necessarily need to speak to anyone in the first instance. That they also look after the Consent Matters module, which is compulsory for all students. So you can contact them via their details on this slide, but if you search Safer Communities on our website, it can also take you to the reporting portal. But it's important to be aware of them because they do a lot of work for our students on campus. We've also got a great university health service, and while you may not be able to go in person at the moment, they still have telephone consultations available. They have both male and female GPs, and they can also refer you to specialists. They've also got sexual health and mental health services within. If you are an international student, they have OSHC direct billing, but it's important that you have your OSHC card ready to go to access that. Our Mana Yura student support supports students who are Aboriginal and Torres Strait Islander. They have academic and administrative support as well as pastoral care support. So they've also got an Indigenous tutorial assistance scheme, and they've a great mentoring program. And they have 2 culturally safe spaces on campus. The Woolly building is on the main campus, and the Urang is on our Cumberland campus. So if you'd like to connect with our Mana Yura Centre, you can do so on the following website at the bottom there. I'd also like to introduce you to our University of Sydney Pride Network. They are amazing. So they're obviously for anyone that identifies with LGBTIQ, but also for staff and allies. So they've got a lot of allies who have joined doing a lot of work within the university. They have a great float at Mardi Gras every year. It's a lot of fun. They've also got student support liaison officers who are basically staff volunteers across the uni, and they can help to support student transition and gender affirmation. And they also provide a lot of information about health, safety and connection with other students in community. They've got a lot of great social events throughout semesters as well, or research periods. So feel free to connect with them. You can find further information on this website. So I've gone through a lot, and there's still a lot more available to you. As I mentioned, it may not be something that you need right now, but it's important to know what's out there. And all we want to do is help you. So please don't ever feel like you can't ask for help. It's what we do. If you do have your phones ready, you can scan the QR code to access the Support for Students brochure. This will basically list everything that I've mentioned plus more. It's handy to save it because, to be honest with you, it's quite difficult to find on the University of Sydney website. So feel free to save that brochure. And if you do have any other questions or want to connect with our team, we specialise in transition and retention. So a student transition and retention team, anything to do with orientation and retention. Specifically, we have a large international student support, and we can also refer you to where you need to go. You can email at us at any of those emails on this slide, and we'd be more than happy to help you. But that is me done.
Thank you very much, Stephanie. This is a very useful information for our students. So before our students start the presentations, let's meet our panelists, Dr. Elisa Hornish, Dr. Yasha Razavi, and Dr. Matthew Sinovic, who will be scoring today's presentations, and we will find out the top 3 presentations at the end of the symposium. I'll also to remind attendees, students, that you will be given access to share your screen during your presentation time. Okay, so, and I also would like to apologize in advance for any mispronunciations. Let's start. Our first presentation is from Dr. Matthew Watson, the clinical translation of artificial intelligence for screening diabetic retinopathy in primary care.
Hi everyone, it hasn't let me share my video, but I'll share the screen whilst we're looking at that. I'm Matt, I'm a second year MPhil student that's been, is that sharing now? Okay. Second year MPhil student that's been working with SafeSight and CSIRO part-time, my full-time clinical roles in Outback WA, looking at eyes here. And I'm really interested in AI and how we can get diabetic retinopathy screening done better in Australia. It's gone from fiction to reality, and on the far right hand you can see we're not measuring AI and diabetic retinopathy screening anymore in academic papers. It's moved, that's TGA approved fundus analyses in Australia, and we got 7 of them so far. So my aim for this project was to see how we could translate that better into primary care, and I interviewed a number of GPs about that, but for this presentation I'll focus on the deep learning side of things that I worked with the CSIRO. So the CSIRO had an algorithm, a deep learning algorithm that they gave me access to, as well as a longitudinal data set of fundus images and some non-image based parameters of participants with that data set. And so I set out first to validate that algorithm, which had already been validated and had been getting 92%, 95% sensitivities on other data sets. In this data set, it performed worse. I got it to 85%, but there was a number of troubleshooting steps that we had to go through. The first iteration of it was quite poor. It missed some quite clinically obvious examples of diabetic retinopathy. That image at the bottom right had proliferative disease, which it missed. Retraining the entire algorithm set on a separate image bank got rid of those errors, but sensitivity was still low, and getting a second grader on board to create a composite reference standard improved things. Finally, where I'm at to now, we've been experimenting with the non-image space side of things, so using things like HbA1c and more classic machine learning techniques like support vector machines to improve those sensitivities even further. But you can probably see as we go along, the number of images that I'm working with decrease. So the scientific validity also decreases as that happens. So the things that I've learned is that being able to explain what goes on in AI is really, really key. And it pertains to this idea of the black box that you hear about sometimes if you follow deep learning talks. The beauty of AI is that we don't have to explicitly code each line, telling the algorithm exactly what to do at each step. You just put inputs and it generates outputs. But the consequence of that is we often don't know what's going on inside it. And I think it's really important because otherwise we're going to have instances like that proliferative diabetic photo that I had, and I can't tell you exactly what it was about retraining the algorithm that meant that we were able to pick it up the second time round, nor what was going wrong with the first iteration and why it was being missed the first time round. So explaining this stuff is really, really important, and I think medicine is lagging behind other image analysis sort of areas. So Google's made big strides with this. This is the photo from their cardiovascular risk factor study where they were able to identify gender from fundus photos, and they used a heat map. And you could see where the algorithm was focusing at the fovea and the vasculature. We've got more advanced techniques. This psychedelic sort of panel here is actually a thing called activation maximization. And what it does is for a given layer in any layer of the deep learning network, it's trying to generate the ideal image so that the network would predict a particular class. So you can see what's going on in deeper layers, and you can figure out what the abstracted process is. Is this layer looking at contrast? Is this layer looking at color? Is this layer looking at corners or edges? So it's a really useful tool, and I really think we need to start using tools like that in medicine. The second thing I've realized is that we have a lot of retrospective data sets sitting around, and these wonderful shiny new tools, and there's a race to use these tools on our old data sets, but I'm not sure they're always fit for purpose, and I'm not sure in my case they were. And for example, not all the participants got fundus images at each visit because it was primarily a neuropathy study. And what we do when we do that is we can introduce bias that we're not aware of. And this is an activation maximization analysis of a dumbbell classifier. And you can see on all the images, they have an arm attached to them. So the images it was trained on all had arms. So the algorithm starts to think, if I'm going to classify things as being a dumbbell, it needs an arm as well. So we can introduce bias without realizing it. And then finally, the other take-home point I've had from my research is constructing a good reference standard is key. It's not isolated to just AI, but I think it's critical in AI again, because it's this context of us racing to publish that it can be missed. And this is a large Google paper as well on diabetic retinopathy, and it was 120,000 images we used.
There's some connection issue here. I couldn't hear your talking.
Or it's at the 5 minutes.
Oh, it's at the 5 minutes. That's right. It's too interesting that I forgot about the time. Thank you, hosts. It's 10 minutes at straight 5 minutes, as I previously mentioned, and now this is a Q&A time. So, any questions for Matthew? Well, I might start one. So how much, I'm not sure if I get it right, but you are given an algorithm by CSIRO to validate it. How much flexibility you have on redesigning the algorithm?
Sorry, how much I had on the redesign of the algorithm?
Yeah.
How much I was doing? Look,
I mean, no, not how much you are doing, but how much flexibility that this algorithm can be redesigned. Right.
I mean, they're quite flexible. A lot of these algorithms are off the box. The algorithm the CSIRO uses is actually called Inception version 3. And most AI that we use, I saw that there's one later in the talk, will be taken from essentially an off-the-box algorithm, and you can fiddle with its internal network and a few other parameters. But it means that AI is so much more accessible than it was before. And for me, then the focus turns away from generating the algorithm, like the nitty gritty of it, to actually having really high quality data and high quality reference standards. And I think that's why we're seeing examples of AIs that are working really well in a very controlled environment, but then we use them on a different data set and they're not doing so well. And so I think, I mean, that's my personal opinion. I'm sure lots of other people have other opinions, but I don't know if I answered your question there.
Yeah, no, I think yeah, that's most of the case that you are given the algorithm, but you can still tweak internally of the algorithm architecture design, and how many hidden layers, how many knots you can increase, yeah. All those things. And if that's what you're doing and you're still seeing there's a disadvantage somehow in the algorithm, then yeah, a new way, as you proposed, for perhaps is a way to go. We have a question from Paul Martin. Your algorithm has 85% accuracy. How accurate are clinicians at detecting DR?
Paul, I don't have that off the top of my head. I think when I was reading some part of my literature review back, some of these studies are quite old and they were done before fundus photography was really a big thing. But some studies estimate that primary care eye carers are as low as 50%. Whether I actually think that's believable or not is another thing. Someone might be able to come in with a more recent.
That's my understanding as well. That optometrists have been, at least in the United Kingdom, they started off actually a screening program that had dedicated sort of photographic services, which were mobile, and dedicated graders, because they performed better than optometrists back in the sort of 1990s, early 2000s. I understand that that's been replicated in other countries as well. I think Scandinavia somewhere. The gold standard, of course, would be sort of a subspecialist in the area.
Many thanks from Paul. I have another question. So how many images, and that's perhaps a naive question, how many images you have for per patient? Is it one fundus image per patient, or you take multiple? And are they averaged, or how do you use them?
So basically, it was highly variable, and it was one of those points at the end about whether my data was fit for purpose, and realizing that it wasn't designed for that. So some patients, because it was a neuropathy focused trial, the clinic nurses didn't always do a fundus image. So some years it would skip. So you could have anywhere between 1 and 5 fundus macular-centered images. Some of the participants got multi-field images. So, 3 to 5, probably not your 7 ETDRS images. But again, it meant that we had all this data that we had to throw out, just focus on the macular-centered ones. With retrospect, I could have held on to that data because that would have been useful for the gold standard grader. So the clinician grading the photo for the algorithm to compare to. But yeah, it was very variable with the data set.
Okay, thank you. So that's the end for question time, I was told. Our next presenter is Dr. Sofia Zagora, pediatric uveitic glaucoma and the advent of biologic therapy. Over to you.
Can you see this okay and hear me?
Yes.
Yes, all good.
Yeah. My name is Dr. Sofia Zagora, and I'm in my first year of a Masters of Philosophy, and I'm looking at pediatric uveitic glaucoma and the advent of biologic therapy. So what is uveitis? It's a generic term for greater than 30 different phenotypes of intraocular inflammation along the uveal tract. It's a rare chronic condition in pediatric population, also known as an orphan disease. The incidence is 4.3 per 100,000 and prevalence of 27.9 per 100,000. 12 to 38% of children with juvenile idiopathic arthritis develop uveitis. It's sight-threatening in our pediatric population in that they often present really late because they're asymptomatic, so they have very severe disease when they present, and also it's actually very difficult to treat, and we have quite a few treatment failures. They develop a lot of complications from cataract and glaucoma. The mainstay of uveitis treatment is steroids for both pediatric and adult population, and we're moving much more towards steroid-sparing agents and biologics. My hypothesis is that the increased use of biologics and other steroid-sparing agents will reduce glaucoma and the need for glaucoma surgery in children with uveitis. I'm doing a retrospective chart review of all pediatric uveitis patients between 2005 and looking forward to 2021, with the inclusion criteria of patients under 16 years of age at diagnosis, all uveitis, and greater than 1 year of follow-up. In terms of where I'm up to, I've developed a REDCap database and I'm in the middle of doing data collection. We've conducted a pilot study which looked at 27 of our patients that were on biologics, and of those patients, there was 23 of them, so the majority of them, 85%, had anterior uveitis and a baseline age at diagnosis of 9 years. In this study, a lot of the patients were on adalimumab, which is Humira, so that's 85%, and then infliximab and anakinra. And we're finding in the last few years that we're also using tocilizumab, and now we have 3 patients on JAK inhibitors. In this population, there was a great increase in visual acuity from baseline to the first 6 weeks that was then maintained at 12 months. And so you're looking at around a vision of 624 at baseline, improving to between 6.9, 6.7.5, and being maintained to 12 months. Also looking at steroid reduction in these patients on biologics, and we know that steroids are associated with glaucoma and cataract. So this is looking at patients that were on greater than 5 milligrams of prednisone at baseline, and there was 33% of those 27 patients. And towards the end of the 12 months, there was 83% reduction of patients in greater than 5 milligrams of prednisone. Also looking at our pediatric patient being on steroid-sparing agents at baseline before starting these biologics, a number of them were on greater than 1 steroid-sparing agents. That was 18.5% of patients, and by 12 months, there was a 50% reduction in this. What's alarming is the number of patients that are having surgeries in this age group. So we're talking glaucoma surgery, cataract surgery, and also vitreoretinal surgery. So 8 patients underwent glaucoma surgery. That was 11 eyes of these patients. So we're talking about a really young population, mean age of 9 years. And so what this has highlighted is that we need to try and reduce this. So I'm looking at a longer data set now from 2005 with a lot more patients. I've identified between 60 to 70 patients. And we're looking at the person years of diagnosis. So in terms of when the diagnosis was made of the uveitis, how long they were on steroid treatment, what dose, and at what stage in terms of years as well, the biologics were started. And then also we're reducing our threshold to start these patients on immune sparing and also biologic agents, because we now conduct a combined clinic with a pediatric rheumatologist. So we find that we have a much lower threshold to start these patients on treatment, and we're hoping this will reduce the glaucoma incidence. Thank you. And this is just a picture of a patient who was on tocilizumab, and the picture on the left-hand side was at baseline, and this is 1 year after, and you can see that there's a reduction in their intermediate uveitis. And this is the power of these biologic drugs.
Thank you very much. Any questions?
I've got a question, if that's all right.
Yeah, Matthew, go ahead.
Right, so it's interesting topic. In terms of the kids who are on steroids, are you, for your analysis, how are you kind of breaking down how they receive the steroids? So for example,
sorry, you go.
Yeah. So you might anticipate with certain modes of delivery that they're more at risk of glaucoma than with others.
Yes, so recording all types of steroid use. So looking at topical use, including how many drops and for how long, then looking at oral use in terms of greater than 5 milligrams, and so the actual milligrams for how long, and then if there's any orbital flaw. We rarely do give intravitreal, but in the past they may have had intravitreal, and also the implant. So every type of steroid use.
Yeah, okay.
Any other questions? Well, as a person who doesn't really know about this disease, can I, is there any relationship between the age of child and the severity of the disease? Or these two are kind of separated, they're not related?
I think they're probably related, but this analysis will help show us, because the longer, we assume that the longer the patient has the uveitis for, the more at risk they are of having complications. And often also depending on whether they've got any systemic associations like JIA, whether they're ANA positive or negative, may also attribute to the severity of the disease. So a lot of it is still idiopathic, but we do have a lot of patients that have associated systemic disease, and sometimes they are more severe. It's bilateral, and so they may present younger.
Thank you. Any other questions?
I got a question. So I assume you expect that the biologics will decrease the number of surgeries required for glaucoma for these patients?
Yes. And we're also hoping that they show an increased success rate with the glaucoma surgery and requiring less surgeries.
Do you capture the delay? Like maybe the biologics mean that they don't have to have the surgeries as early, or will we capture that in that study?
Yes, so that's why I'm looking at person years. So looking at from diagnosis of uveitis to when they started the biologic, and then also looking at from diagnosis of uveitis to the timing of surgery, and also timing of surgery in relation to when the biologic was started.
Thank you. Let's move on to the next presenter. It's Miss Elisa Belluccini, characterization of receptive fields in the mouse retina.
Hi everyone. So I'm just at the end of my first year of my PhD, and today I'll be talking about ganglion cell receptive fields in the mouse retina. So the retina is a light-sensitive sheet of tissue situated at the back of the eye, and this is where the first stages of visual processing occur before the information is sent up to the brain. Here you can see an image of a whole mount preparation of a mouse retina next to the human retina film. Then over on the right is a schematic of a cross-section through the retina where we have the photoreceptors, which convert light into neural signals which are passed through the ganglion cells. Each ganglion cell has a receptive field, which is the area over which light stimulation modulates the firing rate of the cell. So the receptive field properties are also shaped by these intermediate bipolar, horizontal, and amacrine cells. And another way to think of this is that each ganglion cell has a patch of the visual worlds that it looks at, and this is represented by its receptive fields. So traditionally, there have been different methods of characterizing ganglion cell receptive fields. So some of these include spots, gratings, and white noise stimuli. More recently in our lab, a new technique has been developed using a flashing bar stimulus and iterative reconstruction tomography. So this has several advantages, including that it can detect nonlinear receptive fields and also map receptive fields with high resolution. So to collect the data, we perform in vitro whole cell patch clamp recordings of mouse retinal ganglion cells. And so the retinal tissue is placed here in the recording chamber, and the microelectrode is recording the membrane potential and spike responses as visual stimuli are displayed on a screen. So then this is a flowchart showing how we have the raw data that is processed to form the receptive fields maps. So here is an example of 3 different stimuli. So the bars flashed in different orientations and positions over the receptive fields. So for each stimulus, we record the intracellular response. And then when we have the responses to all of the stimuli, we do a principal component analysis to extract the 3 main features from the data. So then we take the response weights from the PCA as the input into the iterative reconstruction algorithm, and this produces the receptive field map. So once I have the receptive field maps for all cells that I've recorded so far, I then went on to look at how these corresponds to the dendritic morphology of the ganglion cells. So here is another image of a receptive fields map with the trace cell anatomy overlaid on it. And then plotted here is a measure of the dendrite density, which is the total length of the dendrites within each pixel in this image. And then this is plotted against the receptive field strength in impulses per second per pixel. So for this particular example, there was a fairly good correlation between these 2 measures. So I repeated this analysis for 5 cells with the R-squared values plotted here, and the average was about 0.44. So additionally, I also wanted to look at how the size of the dendritic fields corresponds to the receptive field center. So I did this using the circular difference of Gaussians model, which estimates the center and surrounds parameters. So here you can see the center estimate as the red circle and the surrounds, which is the pink circle. So for this particular cell, there was a fairly good match between the radius of the dendritic field and the radius of the receptive field center. So that's this point plotted here. And then interestingly, for another 6 cells, the dendritic field radius was actually larger than the receptive field's center radius. So at this stage, I have started to draw a link between the receptive field maps measured by our new technique and the dendritic morphology of the cells. And one of the next steps I'll take is to look at whether this relationship varies with different cell types. Thank you.
Thank you very much. Any questions?
Yeah, could I ask, how many different ganglion cell types are there in the mouse retina compared to, say, the human?
So there are lots of papers that have different ways of characterizing ganglion cell types. So I think that's like roughly 30 altogether, but yeah, it depends on which literature you look at.
And the follow-up question then is, do you know what type of cell you're stimulating or testing before you do the morphology? Or so you do the morphology and then try and match them up afterwards?
Yeah, so in the patch clamp experiment, we like classify them like functionally, so like whether they're in like an on or an off cell, and then afterwards with the morphology, I was just using like one of the simpler characterization methods, which was a paper that basically separated them into like A, B, C, and D cells. Yeah, initially I was just using that method, and the cells that I've recorded so far were B and C cells.
Any more questions?
Yeah, I've got a question. So I enjoyed your talk. With this last slide here, the sort of the dendritic arbor is kind of non-circular, it's more elliptical. Have you considered using a model that takes that into account?
Yeah, so I was also using a 2D difference of Gaussians model, which accounts for that. So I'm still kind of working on like if I'll use the same model for all cells or different models which might suit other cells better.
Yeah, okay, great, thanks.
Thank you very much. Let's move on to the next presenter, Dr. Adrian Hunt. 12-month outcomes of Ranibizumab versus Aflibercept for macular edema due to branch retinal vein occlusion. Data from the Fight Retinal Blindness Registry. Over to you, Adrian.
So hi everyone. So I'm presenting the results of 12-month outcomes of Ranibizumab versus Aflibercept in macular edema due to treatment-naive branch retinal vein occlusion. The results are from the Fight Retinal Blindness Registry, and I'm a PhD candidate there with Mark Gillies. So this is a branch retinal vein occlusion. It has all that edema and hemorrhage in one quadrant of the retina extending into the macula and causing macular edema. This is a cross-sectional image, an OCT, demonstrating that edema. And typically we give multiple injections of intravitreal anti-VEGF therapy, which dries the macula and improves the visual acuity and tries to help that patient. Now, we generally use one of these two drugs that's approved by the PBS. They've been demonstrated through randomized control trials to be excellent in terms of efficacy and safety. And really what happens though then in the real world, we don't really know. And so FRB has this registry that you can monitor the improvement in visual acuity and the reduction in central subfield thickness, whether or not you get injections or not, and how the patient's doing over time. So we used FRB and designed this study. It was a database observational study from 2014 to 2019. It's an international study and it's extended into some new countries that haven't previously been involved, such as Spain, and Ireland's been a little bit involved before. It was a head-to-head, so it wasn't just looking at the real-world outcomes. It was trying to compare the drugs using a generalized additive mixed model to compare and plot those predicted responses over time for 12 months. The primary outcome was the mean change in visual acuity at 12 months, also secondary outcomes, number of injections and switching and non-completion. At baseline, we managed to recruit a very good split of patients, split perfectly really between the two agents with 324 patients, but split 162 each. They were very well matched in terms of age, baseline VA and central subfield thickness. The visual acuity, just out of interest, is around 624, and the maculae in these patients were not particularly swollen. So results, we had good rates of completion, about 80%, over 80%. These are the adjusted results. The mean change in, adjusted mean change in visual acuity was very similar between the agents at 11 letters improvement. It wasn't significant, indicating both drugs are effective. But the interesting finding was the significant greater reduction in central subfield thickness with Aflibercept at 170 microns versus 146 microns for Ranibizumab, and that was very significant. Switching occurred much more frequently from Ranibizumab than from Aflibercept, and the injections over 12 months were around about identical. The mean was 6.9, just the medians look a little bit different there, but it wasn't significantly different, 7 injections. This is the model plot of visual acuity, indicating that very almost complete overlap of agents over time, visual acuity, no difference on the confidence intervals. And this is just indicating that maybe in the last 6 months, there was a bit of under-treatment with 2 injections only given, 5 injections in the first 6 months. The central subfield thickness and the confidence intervals are shaded there in grey, and it indicates that significant difference almost throughout. Just where does this evidence fit in terms of existing evidence? These are the 2 randomized trials that I mentioned at the beginning. they generally started with much more swollen maculae and more room to improve, but they also gave much more, they gave more frequent injections. And that's typically what happens in real world. They tend to undertreat a bit in the real world. And so randomized control trials do better. This was an analysis of multiple small trials. They did surprisingly well. And then some other real world evidence out there from the UK EMR users group and the Luminous post-marketing sort of observational database run by Novartis. The follow-up on these is very poor, 25% only in the UK users group and 46% in the Luminous, but generally less treatment, maybe similar letters, but also they started from a lower visual acuity, so more room to improve. So in conclusion, treatment-naive BRVO eyes receiving anti-VEGF inhibitors in the real world have good outcomes, just they lag a little bit behind their RCTs, the randomized control trials. Ranibizumab and Aflibercept produce equivalent improvements in visual acuity despite a greater effect on macular thickness afforded by Aflibercept. Switching was much more common from ranibizumab, and it probably reflects the market share, and when a new drug arrives, it tends to be supplanted by the new drug. Old drugs tend to be supplanted. Ongoing need for VEGF suppression appears to extend beyond 6 months, with undertreatment likely eroding those peak gains. And we look forward to doing the 36-month.
Sorry, time's up. Okay, it's Q&A time.
Okay.
Any questions? This is a hash. Okay, Matthew, over to you.
I've got a question. Thanks, Adrian. I enjoyed the talk. This is a rather parochial question. Is Australia doing better than the other countries?
Yeah, I think Australia traditionally has a good health system. It tends to get good funding for treatment, and it does traditionally do better. The UK generally is not a huge performer. France seems to do pretty well, but it didn't seem apparent on this study that we were markedly better.
Yeah, okay.
I think it's traditionally AMD that we do.
Yeah, sure.
Compared to others.
There may be a bit more wriggle room with this condition than with AMD. Yeah.
Yeah.
Any other questions?
Paul's got one.
Over to I think we can't hear you talking. Maybe unmute you.
No, Paul has one. So do you want me to read it? Paul Martin. He's asked, thanks for the presentation, really interesting. What causes the branch occlusions? Can you clotbuster drugs to treat it accurately? And he said he's obviously not a clinician.
Yeah, I think probably the first thing to realise is how small that occlusion is. It's really quite small. So we're talking, maybe 50 microns or so the vein at that region. So going in there sort of surgically is very tricky, I imagine. You can give maybe thrombolytic agents, but it really hasn't had any positive studies demonstrating their efficacy. The cause is generally is invariably hypertension. So the artery crosses over the vein at a certain point, and that hypertensive sort of arteriole compresses the vein, and there's a traditional medical principle of Virchow's triad, where you have external compression on a vessel, or abnormality in the vessel wall, or a hypercoagulable state that generally causes clots. And I think in branch retinal vein occlusion, it's usually at that crossing point. So it's that external atherosclerotic arteriole pressing on the vein.
Message you back, phone Paul. Thank you very much.
Thank you.
Another question for Matthew. I see you unmuted. Oh, okay.
question, but I think they are doing a study in Leiden looking at using a surgical robot to actually cannulate venules, but I think that's central retinal vein occlusion.
Okay, so the Q&A time's up. We are ahead of time, so we're going to accommodate for another presentations, and that way we can hopefully finish the event also earlier. And our next presenter is Mr. Dimas Saki. Merck retinopathy, understanding rate of visual loss in the therapeutic era.
Can't hear you, Demas.
Unmute.
You're on mute. Try again.
Unmute.
There you go.
Okay. Hi, I'm Dimas. I will talk about hemertica retinopathy, understanding rate of visual loss in the therapeutic era. Inherited retinal disease, or IRD, is the #1 cause of legal blindness in working population, with retinitis pigmentosa, or RP, as the most prevalent IRD. MER tyrosine kinase, or MRTK, has an essential role in photoreceptor outer segment phagocytosis in retinal pigment epithelium and also in the macrophage. It's also known to inhibit inflammation and autoimmune. In this gene therapy era, the phase 1 of MRTK gene replacement study has been done and currently recruiting for the next phase. The purpose of our study are to identify the most appropriate biomarkers to monitor MRTK RP progression and to identify the optimum time for therapy. To reach our goals, we did retrospective cohort of 5 MRTK RP patients evaluating BCVA, ellipsoid zone, central macular thickness, fundus autofluorescence, semi-automated kinetic perimetry, and ERG from baseline and last follow-up. And the mean age of our subjects was 20.9 years old at baseline and mean follow-up of 51.4 months. We had 4 female and 1 male and found novel homozygous mutation in patient 4. BCVA declined 0.07 logMAR per year, leading to legal blindness in 9.7 years. Central macular thickness was declining 1.7 micrometer per year, but 5 eyes had an increase. It might be due to poor fixation. An ellipsoid zone line was also declining at 137.01 micrometer per year. In figure 1, we can see one patient with bilateral optic disc swelling 8 years before RP diagnosis with normal MRI and intracranial pressure. So in case of unexplained optic disc swelling, we should consider an underlying retinopathy. And in figure 2, we can find macular hyperautofluorescence with patchy, granular, and annular pattern with same pattern and minimal difference on baseline and last follow-up. Semi-automated kinetic perimetry results were relatively preserved peripheral visual field. And full field ERG and pattern ERG were barely recordable. MRTK in RPE phagocyte photoreceptor outer segment. Therefore, its defect will cause lipofusion accumulation. It's an autofluorescence material. Greater phagocytic load at macula results in macular hyperautofluorescence. The results of MRTK gene replacement phase 1 trial were 3 out of 6 improved patients. These 3 only had 1 injection site, and 2 of them, including the youngest, had better initial visual acuity compared to others. Therefore, it might suggest early intervention. And MRTK also has been linked to acute anterior uveitis, further proving its inflammatory component. So our conclusions are ellipsoid zone line is more reliable than central macular thickness or fundus autofluorescence for monitoring MRTK RP progression. Early vision loss and rapid degradation reflect genetic deficit in the RPE and affecting both rod and cone photoreceptors simultaneously, not within the rod photoreceptors as seen in the other RP. These findings provide guidance to timing for early intervention with future therapeutic clinical trials. Thank you.
Thank you very much. Questions?
Thanks very much. I've got a question. So you mentioned that there's progression to legal blindness by within 9.7 years. What's that from? From what baseline?
Okay, thank you. The baseline is from the best patient in the baseline, the patient with the best visual acuity at the baseline. So we calculate that with the rate of the loss, and then we find 9.7 years leading to legal blindness.
And I mean, typically the loss of visual acuity in these patients is non-linear. So yeah. It's, I guess it depends on what you kind of choose as the starting point in a way. So you're averaging for patients in different stages who may have different rates of a non-linear decline. I'm just not sure what you can say that based upon the data.
Okay, yeah, I mean, it just reflect that from the best patient, from the patient with the best visual acuity, he or she can get legal blindness in 9.7 years. It might be just reflect that point.
Any more questions? Okay, I think we can conclude this session. We have 10 minutes break. Just a small change for the next session, as Dr. Calvin Teal needs to attend a clinic, so he will be the first person presenting in the next session. And we'll see each other back at 10:20. Thank you.
Good morning, everybody. My name is Kelvin. I'm a PhD candidate, and my supervisor is Professor Mark Gillis. And today I'll be talking on the detrimental effects of delayed treatment in neovascular AMD. And some of this data is coming from the Fight Retinal Blindness Registry. Now, we all know what real-world data is and how useful it is. And just besides correcting good outcomes for our patients in clinical practice, really the question is, how can we use some of this data to translate into our clinical practice? And here I'll be talking about in the context of age-related macular degeneration treatment. And I suppose first we look back at what we based a lot of our evidence-based practice on. And to those of us that are treating AMD patients will be very familiar with these curves. This is the Merinda and Anchor curve, and these were the registration trials for anti-VEGF treatment for AMD. And these showed good outcomes with monthly anti-VEGF treatment. However, obviously, with this close monitoring and monthly treatments, it equates to very high treatment burden and unsustainability in real-world practice. And so we moved on to talk about more relaxed regimens, as-needed regimens where patients will come back monthly, and if there's active disease, they'll be treated, or treat an extent where patients would be treated at every visit. But if disease was inactive, they were allowed to have an extension of their treatment interval. And good evidence there that looks at some of the effectiveness of these regimens, but still really in the realm of clinical trial. What happens in the real world? So this is Aura study, which was a large multi-European study which looked at real-world outcomes over 2 years. And here, the results are markedly different from what we see even in some of these more relaxed regimens where patients were getting back to baseline vision, some as early as up to 1 year of treatment. And when they plotted these vision gains with the CAT study, which is another big clinical trial, we found that really nobody came close to getting the same kind of outcomes. And they attributed this really to the fact that patients in real world practice were undertreated. If you look at the number of injections there, we're talking about 13 injections, almost 13 injections in the as-needed arm in the CAT group. And really, the highest was 9 injections over 2 years in some of the other real-world cohorts. More evidence on this. This is the Luminous study, which looked at multi-country outcomes. And again, same thing with low injections, low vision gain, with high injections, high vision gain. If we look at our own evidence here in the Fight Retinal Blindness Registry, in this 2-year treat and extend outcome study, we found decent gains in vision, again, with substantial numbers of injections over 2 years. And really, this is what it encompassed. More frequent visits, more injections were associated with greater vision improvement. And if we plot the FRB curve there against aura, we find that we're not doing too badly. So that concept is quite clear. Under treatment equals to poorer outcomes and vice versa. More treatments equals to better outcomes. But how does this actually relate to me in the clinic? It doesn't really tell me when to treat or how. And so in a real world practice, we're already laden with inherently disadvantaged patients because number one, patients dislike injections. Number two, they have a lot of difficulty in follow-up. And really, this is the biggest thing, patients never listen to their doctors. And this really disadvantages patients to having having enough treatments to get a good vision gain. And we often get into what I call the bargain in clinical practice. And this is an example. A patient would have a number of injections. He would come back. It looks like looking something like this with a bit of activity, vision of 6/18, and he would go, "Doc, my vision's been pretty stable for a long time. I don't think I need an injection today." We'll have a little bit of to and fro. And eventually I would relent. He would come back. I would ask him to come back a month, but he'll come back 2 months later. And he would look pretty much the same, with the same vision. And again, he would go, "Doc, look, I didn't have an injection the last time. I'm still doing quite well. I don't want an injection today." I relent. And then he comes back 2 weeks later and with an increase in activity and drop in vision. Here's another example. And for those of you that are familiar, this is an Asian type of AMD, a PCV, with a little bit of activity, similarly refusing injections. Again, a little bit of activity, refusing injections, and a short while later, coming back with a massive subretinal hemorrhage. So these are not uncommon patients, and I see this in my clinic fairly regularly. And what these eyes had in common was really that these patients missed treatments while disease was active. And here, intuitively, most physicians would treat active disease, and we wanted to look at this effect directly and its effect on vision outcomes in real-world practice. And the thought here was that at the very least, a recommendation that we could make from real-world evidence was that active disease should be treated regardless of whatever interval they were coming back at. And so this.
Sorry, Kelvin, I think you run over time, so you're automatically muted. This is the question time now. I'll have you unmuted. So any questions for Kelvin?
What were you going to tell us, Kelvin? Just quickly.
I was going to tell you that treat active disease regardless of whenever you see it. And that really the number of injections didn't make a big difference.
Right.
I'm quite curious when you mentioned that the 3 disadvantages to the injection, that the patient are not complying, patient doesn't like injection. Do you know which factor is the most significant factor towards to that, or they all kind of share equal weight?
So actually what we found within this analysis, in a sub-analysis, was that there was a group of patients that didn't conform to this were either persistent disease, so patients that got sick of getting treatments, or recurrent disease, so patients that did well and then became a little bit complacent with their treatments and then to refuse to come back for follow-up.
Any other questions?
Calvin, I mean, it's very interesting, and it's human nature for both the patient and the doctor. Do you think there's we all searching for the long-term acting, anti-VEGF drug. Is there a role in some of those to sort of have some sort of, one of the steroid things, the original work that Mark did years ago, but is that something that would tide those people over when they're not looking active?
I think so. So that was the last slide. With persistent disease, I think that long-acting agents would probably help to address at least that portion of patients. Then, of course, with recurrent disease, if the same agent was very effective, then that would also address that particular group.
Any other questions for Kelvin?
I think Adrian Hunts wants a question. So you need to mute him, I think.
I'm trying to find him.
Can you hear me there?
Oops. Okay. Adrian, I think you can talk now. No? Are you able to talk, Adrian?
Yeah, Kelvin, can you hear me now?
I can.
Yeah, I just wanted to ask if there's a whole lot more work to do in terms of the clinic management, like examining every patient, every, visit, no treatment-only visits, no sort of, no one's really set in a railroad kind of way. It must create a lot more work, does it not?
Sorry, say that again, Adrian. Hello.
Can't hear you, Kelvin.
Hello.
Yeah, we can hear you now.
Okay. Sorry, I missed the question, Adrian.
Oh, does it create a huge amount of work having to do all that extra review, etc., rather than having people on more of a treat and extend approach where you really only adjust if things are going badly or going really well?
So I mean, that's assuming your patients are obedient and follow your instructions and come back for the injection-only visits. So I mean, here this was blinded to the fact that patients might miss their visits and they might come back 3 months later or 6 months later. I think the idea here was that if you see active disease, treat it in a real-world context, because these guys are not going to follow your instructions and do a nice T&E for you or do a nice monthly visit for you, at least in where I'm practicing. In Australia, of course, it's a little bit different. All your patients are actually very, very well behaved, and that's what I found when I was practicing there.
Thank you very much. The Q&A time's up. Again, thank you, Kelvin. Our next speaker is Mr. Nasil Udin, compelling structural evidence for lymphatics in posterior human optic nerve meninges. So here we go.
So, hello everyone. So I'm Mohammad Nasruddin, and today I'll be talking about evidence of lymphatics in human optic nerve meninges. So the lymphatic vasculature represents a second circulation parallel to the blood vasculature. The lymphatics remove interstitial fluid and macromolecules, including proteins, and transfer them to the lymph node before entering the blood circulation. So another function of lymphatic is to carry immune cells to the lymph node and to control immunity in health and disease. So lymphatic lymphatic vessel has been reported in the various parts of the eye. So in the anterior eye, the lymphatic has been reported in corneal limbus, conjunctiva, and ciliary body. On the other hand, in the posterior eye, lymphatic has been reported in choroid and in the optic nerve meninges. However, the evidence of lymphatics in the optic nerve meninges is very limited. So therefore, this study was carried out to provide strong evidence of meninges in human optic, strong evidence of lymphatics in human optic nerve meninges. So 12 adult human eyes were used in this study. So we also did histological staining with tau blue and multi-marker immunofluorescence with the lymphatic marker D240 which is a clone for podoplanine, a lymphatic marker, and a blood vessel marker UA-lectin. We also carried out ultrastructural characterization of meninges. So this image shows the basic anatomical feature of the meninges. So optic nerve parenchyma is surrounded by meninges, and meninges is composed of 3 layers. The thin and innermost layer is pia mater, and then thick outermost layer is dura mater, and the middle layer is arachnoid mater. And this empty space is known as subarachnoid space, where cerebrospinal fluid flow through. And this arrowhead shows arachnoid trabeculae, which connects pia mater to arachnoid mater. So optic nerve parenchyma and its surrounding meninges were immunostained with lymphatic marker D240, which is shown as a red color, and blood vessel marker UA-lectin, which is shown as green color. And this inset shows the location of meningeal lymphatics. This high power micrograph shows that a thin collapsed lymphatic capillary was found in the optic nerve meninges. This merged image shows that this lymphatic capillary was very close to UA-lectin positive blood capillary. So at this point, we don't know the exact location of lymphatic capillaries within the meningeal sheath. So to achieve this, we carried out ultrastructural characterization of meninges, and this is a representative TM image of meninges with different parts. So basically this area shows the subarachnoid space, and this area shows the adjacent arachnoid mater. And based on the ultrastructural characterization, we found that lymphatic capillary is precisely located within the arachnoid mater, very close to subarachnoid space. So this finding is interesting because since the lymphatic capillary is very close to subarachnoid space, so it means that it is capable of collecting excess fluid and metabolic waste from the cerebrospinal fluid and transfer them to the lymph node in head and neck. So therefore, these meningeal lymphatics might play an important role in fluid homeostasis and metabolic waste clearance from the back of the eye in health and disease. Thank you very much.
Thank you. Any questions?
Thank you for that interesting presentation. Is the ultrastructure of these channels similar to the choroid plexus channels in the brain for draining CSF, or are they sort of different?
So you mean that lymphatics in the brain meninges?
Yeah, and because and also compared to the normal drainage of CSF out through the choroid plexus, their processes, because it drains the CSF out, so how, or produces it, how does that work there? How does it compare to other parts of the CSF, central nervous system?
So, so this result of this optic nerve meningeal lymphatics is very similar to the finding of meningeal lymphatics in the brain, and yeah, and the only the difference is the location. So in the brain, so far the most of the report is the meningeal lymphatics in the brain. It is located in the dura mater. But in our study, we found that in the optic nerve, the lymphatics is in the arachnoid mater.
There was an interesting talk. Do you have any idea about where they drain into?
So yeah, so we did the functional tracer studies into the in a rat model, and we found that this lymphatic is drained into the deep cervical lymph node.
Okay, thank you.
Thank you. We have a question for Michelle. So I'll just read it out. Good talk, thank you. What features used to define lymphatics? Are other immunomarkers to be used? Is there any yes, sure.
Yeah, so for the immunomarkers, so I only showed the G240, but we also used the live one, and also we used VEGFR3 as other lymphatic marker. And so basically, so our So we used extensive ultrastructural characterization of lymphatics, and for the lymphatic capillaries, our ultrastructural criteria was the presence of anchoring filament, which is the gold standard criteria for lymphatics. And we also look at the absence of the erythrocyte and the presence of poorly formed junction, unlike the blood vessel where it is present as tight junction. So yeah, and also we also checked. We also found that in the lymphatic there is no viable palladi body, which is present in the blood vessel endothelial cell.
Thank you, Michelle's reply. Thank you. Good choices. Also good EM criteria.
Thank you.
Thank you. So that's the time for Q&A. We can move on to the next presenter. Just a kind reminder for all the presenters, please turn on your video if you can during your presentation. Okay, so our next presenter is Ms. Ri Zhang. Selective knockdown of hexokinase 2 in rods leads to age-related photoreceptor degeneration and retinal metabolic remodeling. Over to you, Ri.
So hi everyone. Today I'm going to just present part of it. Selective knockdown of hexokinase 2 in rods leads to retinal metabolic remodeling. Firstly, let me introduce the background. In most cells, glucose are metabolized to pyruvate, and then pyruvate enters mitochondria to generate ATP. If the oxygen is inabundant, pyruvate is metabolized to lactate. In proliferative cells, such as photoreceptors, most pyruvate are metabolized to lactate, even if oxygen is abundant. This is called the Warburg effect. However, the reason why Warburg effect is conducted in photoreceptors remains unclear. But previous studies have found that hexokinase 2 might be a key factor. It is the first rate-limiting enzyme in glycolysis, and it also regulates the function of mitochondria. We have also found that loss of HK2 leads to retinal degeneration. Our group has created transgenic mice with selective knockdown of HK2 in rods. As shown by the immuno, the expression of HK2 reduced in the inner segment of the retina, indicating that our model is successful. And then we studied two key enzymes in glycolysis. The first one is hexokinase 1. It is another isoform of hexokinase. We found that its expression increased in the inner segment of HK2 knockout retina. This might be a compensation by the retina after loss of HK2. And then we studied pyruvate kinase muscle type 2. It is the enzyme that generates pyruvate. We found that the expression of PKM2 stayed unchanged, but it is highly phosphorylated in the HK2 knockout retina. So taking all this together, loss of HK2 changed the enzymes in glycolysis. So how about the enzymes in mitochondria? We focus two enzymes. The first one is PDHE1 alpha. It converts pyruvate to acetyl-CoA. We found that the expression of PDHE1 alpha increased in the inner segment and also the outer nuclear layer of the HK2 retina. HK2 knockout retina, I'm sorry. And then we studied oxoglutarate dehydrogenase. It is a rate-limiting enzyme in the TCA cycle. Just similarly, we found its expression increased in the HK2 knockout retina, especially in the inner segment. So knocking down of HK2 led to upregulation of enzymes in the TCA cycle. To study the metabolism of the retina, we conducted intraperitoneal injection of carbon-13 labeled glucose to our mice, and then we collect the retina after 1 hour, and then we run mass spec to study the metabolites. We first focus on glucose and glucose 6-phosphate, which are the substrate and product of HK2. We found glucose accumulated in the HK2 knockout retina, and the ratio of G6P to glucose reduced. This indicates that although there is upregulation of HK1, it is still not enough to compensate the loss of HK2. And then we studied pyruvate. We found that the level of pyruvate decreased in the HK2 knockout retina. This might be explained by the highly phosphorylated PKM2. In the end, we found that the metabolites in the TCA cycle increased to different extent after knockdown of HK2. This indicates that the TCA cycle is more activated than before. Here is our hypothesis and conclusion. Under normal circumstance, pyruvates are metabolized to lactate, and few of them enters the TCA cycle. But in the HK2 knockout retina, the expression and activity of enzymes has changed. More pyruvate enters the TCA cycle. That's why it is more activated. This might be an adaptation of the retina, and this might explain what it suggests that metabolic disorder is related to retinal degeneration. In the end, I would like to say thank you to my supervisors, Mark and Wei Yong, and our RA Sora, our collaborator, Jianhai, as well as our sponsor, LMRI. Thank you all for listening. Thank you.
Thank you very much, Ray. Q&A time.
Thanks very much. I enjoyed that. Do you think one of the advantages of the Warburg effect might be sort of decreased generation of free radicals in photoreceptors, because they're pretty metabolically active and they're quite active overnight?
As I'm concerned, the Warburg effect, one of the advantage of Warburg effect is to generate metabolites to rebuild the outer segment.
Yeah. Okay.
I think that's why that's how it prevents retinal degeneration.
Any other questions?
Yeah, look, thank you. That was a lovely talk and wonderful histology. My question is, you've knocked out the whole HK2. Do you have any evidence if you had partial function of that gene, does it have an effect? And what sort of impact might it have clinically?
Till now, the first question is, it is not a 100% knockout. According to our Western blot, it's like 90% knockout. And secondly, about clinically, there's no clinical case about HK2 mutation. But very interestingly, HK1 mutation might lead to retinal degeneration, because there has been some case report about it. So it's still mysterious.
Thank you.
Any other questions? So you studied the HK2 mutation, and does the HK2 pathway the same in mouse compared to human?
I think it's similar, because they are firstly it is always the first rate limiting enzyme, and secondly, it always reacts with the mitochondria via VDAC. So I think it's similar.
Thank you. Okay, let's move to the next speaker, Dr. Jack Lucius, the effects of open-angle glaucoma on conventional aqueous outflow, visualized by hemoglobin video imaging.
Thank you very much. So my name is Jed Listhouse and I'm a PhD candidate in my first year. My research is looking into how glaucoma affects the natural drainage of aqueous fluid from the eye. I'd like to acknowledge my supervisors, Peter McCluskey and Keith Martin, for their excellent support, and also Paul Meyer, who developed the hemoglobin video imaging technology. So in the eye, aqueous fluid is produced by the ciliary body. It then travels into the anterior chamber and drains out through the trabecular meshwork into a series of vessels that connect with the episcleral venous system on the surface of the eye. Traditionally, it's been difficult to image this part of the anatomy, but with advancements in OCT technology, aqueous veins have been visualized, but this really only shows the structure of the veins, not the functional flow through the veins. So to do this, intraoperative invasive procedures have been required, involving injections of dyes into the anterior chamber and Schlemm's canal. But now with the addition of hemoglobin video imaging, we can visualize aqueous draining through the episcleral venous system with a clinic-based imaging tool similar to a slit lamp setup. This doesn't require any dyes or contrasts. So in terms of preliminary data, we've been able to describe a technique to quantify aqueous outflow to a certain degree. We can measure the aqueous column diameter, and in the schematic in A, the image A, you can see the central aqueous column, which is surrounded by venous blood. Image B is a hemoglobin video imaging still, and this demonstrates that aqueous column bordered by blood columns. The yellow transept is generated by image J software, and that takes a slice through the vessel, which corresponds to the graph on the right. In terms of that graph, there are two troughs. Each trough corresponds to the blood column. So that gap between those two troughs is the aqueous column diameter. That is then a calculation is made to convert that to aqueous column cross-sectional area, which is in micrometers squared, and that better represents the size of the aqueous column. And we've shown in an early study that in a group of glaucomatous that were going to undergo trabecular bypass surgery with iStent inject, their aqueous column cross-sectional area was significantly lower than normal controls. In those 15 patients that went on to have trabecular bypass surgery with iStent inject, there was an improvement in aqueous column cross-sectional area, but it was a gradual improvement. It took about 3 to 6 months for the eye to settle and find an equilibrium. And this tells us that the trabecular meshwork, as suspected, is only part of the story of resistance to outflow. And there are likely other mechanisms within the episcleral venous system that are impacting on intraocular pressure regulation. The video on the left demonstrates variation in drainage. You can see an aqueous column which is pulsating against a venous column due to cardiac beats, and then all of a sudden the venous column falls away. So it's this type of variation in flow that may indicate regulatory mechanisms within this system. So my plan is to try and stress some of these mechanisms and stress the aqueous outflow system in different ways to try and elicit responses and study the differences in the way glaucomatous patients respond compared to normal controls. This is just one simple example of a manipulation. Pressure is placed on the globe, and there is a flush of aqueous right there, and then flow resumes after the pressure is removed. Other manipulations I plan to perform are the water drinking test and Valsalva maneuver to see differences in responses, and then also look at differences in physiological outflow by comparing hemoglobin video imaging with structure imaged by hyperparallel OCT. So I expect that we'll be able to identify regulatory mechanisms and find impaired mechanisms in glaucoma patients this will help to lead to early diagnosis and treatment options in the future. Thanks very much.
Thank you very much. Questions?
I enjoyed your talk very much, Jed. It's a nice technique. The quantification will depend depends on sort of the optical density of hemoglobin, right? In the vessels.
Yeah, so there are some vessels where quantification is not possible because the vessel is full of blood. And we have been able to demonstrate that flow can be re-established. So yeah, there are variations, but these measurements can be measured longitudinally over time. And during the follow-up of those patients that had the iStent inject, there were times when the vessels were full of blood in the probably 1 week after surgery, and then they re-established flow. So yes, there are variations there.
And this is certainly probably something that Dr. May would have looked into, given his sort of interest. Do we know how much it kind of varies with things like your hematocrit and mean cell hemoglobin?
Good question. I don't know the answer to that. I'll ask him.
Yeah, he probably has done it. Yeah. Thanks, Jed.
Thanks.
Probably got 10 years data.
Yeah, probably.
So Mark, I see you raise your hand.
I've got a hand up. Yeah, so Jed, that was very nice images. So are you suggesting that after you lowered the pressure with an iStent that the aqueous outflow improved?
Yes, so
Why would that be?
there's less resistance to flow, so more fluid is draining out through the system.
Right.
Okay. And we also have 2 questions on the Q&A channel. One from Adrian Hunt. Do you think you will be able to target iStent injection locations?
That's a good question, and something of great clinical interest. I do believe that it will be possible. The question is, do we target vessels that do not currently carry aqueous fluid, or do we target vessels that do carry fluid and try and improve or enhance that drainage? So that's certainly something that will be on the cards for the future.
And another 2 questions from Paul Martin. How does hemoglobin imaging work in a nutshell, please? And second, is this flow pattern appears to be laminar. Do you also see turbulence or mixing of the components?
Yeah, so I'll just answer the second question first. So the laminar flow is what is measurable. Turbulent flow is sometimes seen, particularly in the transition after those eyes underwent iStent inject, and that at this time is not measurable. So those patients were classified as having aqueous that was visualized but not measurable. In terms of how it works, essentially the filter that's used in the slit lamp setup allows a very short wavelength of light to come through, and the hemoglobin absorbs that, so it appears dark against the white scleral background, and the aqueous is clear, so that's how you can see that contrast.
Thank you very much.
Thank you.
Okay, so our next speaker is Mr. Dylan Kirkpatrick. Binocular vision and tunnel-mediated development facilitates innate defensive behaviors in mice. Over to you, Dylan.
All right. Hello, everyone. My name is Dylan Kilpatrick, and I'm going to be presenting an overview of some of my work looking at the role of binocular input on ethologically relevant behavior. So just to get some terms out of the way, innate behavior is any hardwired response to a cue without prior experience The kinds of innate behaviors I'm talking about typically demonstrate very little learning effects, and they run to completion once initiated. So this is thought about in terms of ethology, which is a study of animal behavior that stresses the importance of the animal's natural or evolutionary context. And I'm particularly interested in feature detection in this context, which is the filtering of complex natural stimuli to extract the most important and behaviorally relevant cues from the environment. So a lot of this has been done in the terms of a recently described behavior in mice, which is the looming avoidance response. And it is broadly divisible into two main categories. This is where the animal either freezes for some duration or flees, likely to a shelter, and it can be a combination of these in a rather complex manner. So interestingly, it seems to be primarily behaviorally specific to the dorsal portion of the animal's visual field, which correlates with, based on eye movement studies in rats, to be the area of greatest binocular overlap. However, this does extend in front of the animal in a rostral or frontal direction. So it seems that it's likely to be transduced by a particular subset of retinal ganglion cells. However, work is still being done to elucidate what the most likely candidate is and whether or not it is a single or a combination of different cell types. And the basic circuit flows from the retina to the superior colliculus to a very interesting competitive network between the lateral posterior nucleus of the thalamus and the parabigerminal nucleus. These inputs get integrated at the level of the amygdala and periaqueductal gray network to then lead to a behavioral response. So we know that to some extent the behavior can be modified by visual cortical input, as well as some other areas in thalamus and potentially extrastriate areas. However, a lot of this still remains unclear. And importantly, as does the role of binocular input. It's somewhat inferred by the eye movement studies that correlate with where the response is most likely to occur, but this hasn't been studied directly. So this is what some of my early work focused on, where we directly inactivated one eye using a sodium channel blocker, and we found that it diminishes flight behavior. So this began with a monocular injection of a sodium blocker. We confirmed the blockade using the pupillary light reflex. And first we look at pre-stimulus behaviors to control for any baseline differences that could be occurring as a result of the drug or any other factor. So we look at things like cumulative distances and velocities and find no difference between these paired groups. In the post-stimulus phase, we find that under monocular conditions, mice take longer to exit a predefined region. They demonstrate decreased mean velocities during exit, and they are also in the monocular condition much less efficient at exit. So I've also been applying this to the tenurin gene family knockout animals that we work a lot with. So this has been recently described and published regarding 10M3, where we've been doing a bit of behavioral phenotyping with them, and we've now moved on to the 10M4. So just quickly, tenurins are a gene family that are involved in axonal guidance, and they're critical for the development of the visual system, specifically binocular circuits. So 10M4 deletion specifically results in an increased size and mapping of the ipsilateral projections on their way to the superior colliculus and visual thalamus, the dorsolateral geniculate nucleus. So when you present this looming stimulus from above the animal, as shown in A, you see that in the knockout animals, we get a much slower post-stimulus flight dynamics. And when we looked at that more closely, we saw a profound increase in freezing behavior, which is quite unexpected when a shelter is present in the behavioral paradigm, because typically that biases the response to fleeing. When presented still within what we take to be the binocular field based on eye movements, but presented more frontal to the animal, we find that this more or less abolishes the response, which was quite interesting. So yeah, the frontal presentation based on single point tracking suggests similar flight dynamics between genotypes. However, we think that there is something going on here that single point tracking is not adequately able to capture. So to move on to some limitations of this approach, firstly, manual tracking is really labor intensive and it limits the depth of analysis I can perform. So behavior, as everyone would know, is complex, and subtle differences are not captured in something like a single point analysis. So it's hard to infer 3D pose, head pitch, orientations, and automation of this has not really been feasible via traditional means, especially in a dynamic scene where stimuli are changing, different light levels, and background subtraction simply does not suffice.
Okay, sorry, your time's up. Okay, any questions? I guess an obvious questions maybe what is your conclusions? What are your conclusions from your study? Okay, so can you talk now? Good.
Yes, can you hear me?
Yes.
Yes. Well, conclusions are difficult at this point because, well, firstly, in terms of the 10M4 animals, what seems to be happening is that the distribution of ipsilateral projections along the mediolateral axis may be synapsing with parvalbumin positive cells that alter the competitive interactions between these two thalamic structures. However, it's hard to conclude that without doing more extensive histology. So the conclusion that can be made at this point is that minimally binocular vision at least facilitates this ethologically relevant behavior in mice, and that the genetic knockout of tenurin genes is able to reliably bias of responses that are in a highly stereotyped manner towards freezing. So they are the main conclusions.
Thank you. We have a question from Paul. Thank you. Does anyone know how these freeze-fly responses work in an open environment, not in a box as your mice are?
So in a more open environment than the box, I haven't seen this study. That would be truly ethologically relevant. However, I haven't seen that done. It's simply, it's quite difficult to coordinate the triggering of the stimulus in the correct location in a larger environment. So I've started looking into setting up beam breaks in a larger environment so we can investigate that, but I'm not aware of that being done to date.
There's a nice talk. Can I ask, does it vary with the age of the animal as sort of maturation, the visual system occurs, particularly in your knockout? At what age do you have to standardize for?
Yeah, so what age do we start looking at? I think that in most of these experiments, we've been looking around P25, I think is when we start testing for, and we allow a couple of weeks from there. So we plot plus two weeks or so. We've been looking with some of the work that I've been doing with Matt. We've been working with slightly older animals because we're looking at age-related retinal degeneration as well. And so that's been some new territory, but primarily P25 onwards to about a few weeks.
Thank you, Dylan. Let's move on to our next speaker. Dr. Mei Chu, assessing agreement of clinical estimation of vertical optic disc cupping against RETCAM assessment in the premature neonate and prospective observation of changes. So over to you, Mei.
Trying to unmute my speaker.
You are now unmuted.
Right, hello, good morning, esteemed colleagues. Hello from Malaysia. I would like to present my study on premature infants, and the aim is to assess agreement between the indirect ophthalmoscope to the RETCam assessment of the optic disc, and to look for changes in vertical cup disc ratio during the period of retinal maturation. Lastly, to look for changes in cupping between different birth weight groups over time. Some of the methods that have been reported include Optos, Heidelberg, and RETCam, but they're usually reported on older children. This study is a prospective observational study on infants in an ROP, retinopathy of prematurity screening program. And the patients were examined at 2 different time points, at the beginning of the ROP screening, that's time point 1, and at the discharge from ROP screening. The RETCam images were taken centered on the optic disc to derive the average vertical cup disc ratio as shown here. A masked observer will retrieve these images and take these measurements, whereas the BIO examination is done by the clinician. The exclusion criteria includes enlarged cornea of more than 10 millimeters, intraocular pressure of more than 21 millimeters mercury, and abnormal eye. And the statistics that we used are as follows here. In total, 504 RETCam images were captured from 126 eyes in 63 infants. There was a dropout rate of 12.5%. As you can see here, 65% of the observations differed between RETCam and the indirect ophthalmoscope. The average vertical cup disc ratio was 0.3 by BIO and 0.32 by RETCam. Objective 1, agreement of methods. The intra-class coefficient correlation demonstrated moderate correlation. However, on the Bland-Altman plots, there was very wide 95% of limits of agreement, showing that they are not interchangeable. Reviewing change over time. The BIO showed more varied change over time, but the RETCam showed tighter variation. But what was more important was that in both methods, the changes over time was within 0.2, which is taken as of clinical significance if it is above 2. So there are a few outliers. And the third objective was to look at differences between birth weight groups. Individual PET t-tests showed significant change in vertical cup disc ratio between the 2 time points for birth weight groups 1,001 to 1,500 grams. But the trend of change over time was actually identical for both methods. So the optic nerve is still developing at the time of birth up to the age of 2 years. And any assault onto the nerve will result in irreversible changes, like this one very small optic nerve, and this one very thin neuroretinal rim and very large cupping. Both methods were not interchangeable, but each method gave similar trend of change and variation were not over 0.2. The difference between method is possibly due to color difference, which is assessed through the RETCam, and actual cupping, which is better seen with the BIO. Hence, we recommend documenting vertical cup disc ratio at final ROP screening to serve as a baseline due to the earlier variations. The limitation of this study was a small study population. Inter-observer variation was not studied. So in conclusion, RETCam and BIO estimates are not in agreement or interchangeable. The mean vertical cup disc ratio for this population was 0.3, and the majority of change over time did not exceed 0.2. Different birth weight groups did not have significant change over time. Thank you.
Thank you very much, Mei. Any questions?
Jing, can I ask a question?
Yes, sure.
I'm Mei. So what was the quality of the photographs and what percentage of the photographs were ungradable? And was that because of a dropout rate?
We actually took several photographs, and the best 2 was taken to assess the cupping.
Does that answer your question, Mark?
Yeah.
So you would say that you were able to get adequate images in all eyes?
Yes, because the person who took the images would just take and look at the pictures before we actually delete the ones that were unclear.
Right.
Yes.
And was it easier to do the camera than to do the indirect ophthalmoscopy?
The indirect was quite easy for those of us because we regularly do the ROP examinations. It's the RedCam images that were quite difficult to take because the babies were awake.
Right.
Yeah.
God.
Any other questions? I have a quick one. So in your conclusion, you say RedCam and BRVO estimates are not in agreement or interchangeable. You recommend that both of them need to be used? Or
oh yeah, what we mean by not interchangeable is that you can't say have one reading that is done on RedCam and then 3 months later when somebody looks at it with a different method like just the BIO and then say, oh, then it's we should just follow this. So if you take RedCam image, then the next follow-up you should do a RedCam as well. So but we recommend that we should do both. So for better comparison.
okay. Any other questions? If not, we are running ahead of time, and therefore Dr. Jackie Ten from our next session will be presenting now. So over to you, Dr. Jackie Ten. Your topic is a novel infrared laser activated tryptophan-based thin film adhesive for sealing full thickness corneal laceration in rabbits.
Morning, everyone. Sorry, that's a bit of a mouthful. My name is Jack. I'm a PhD student. I'm calling from Adelaide this morning, and that picture is actually taken in Busselton in Western Australia. Beautiful, isn't it? Today I'm presenting the in vivo arm of my PhD study, where we are looking at a corneal adhesive specially designed to seal full thickness corneal lacerations. Straight into the background. So much different to all the other presenters, moving to the front of the eye now. So if you've got a full thickness corneal laceration, the steroid intraocular contents can leak out, and badness from the outside world can enter the eye too. So for example, if you've got any pathogens lurking in the precorneal tear film and it gets into the eye, and a significant amount gets in, the eye can develop an ophthalmitis, which is sight-threatening. So there's an urgent clinical need to seal corneal laceration as soon as you can. So the current methods of closing full thickness corneal laceration is if the wound is small enough, you can leave it to self-seal, or you can apply some sutures. Now sutures can cause more damage to surrounding cornea. It can cause a bit of warpage. It can cause infection. It can cause foreign body sensation to the patient. Or you can use super glue like cyanoacrylate, or you can use fibrin glue. Now there are newer ones, newer corneal sealants such as Resure and OcuSeal. Now these new sealants are not yet available in Australia, but the experience from our American counterparts suggests that these sealants cures really quickly. So within about 30 seconds, this sealant gets all sticky and stuck and can no longer be applied onto the corneal surface. So here in SafeSight, we developed a new chitosan-based thin film laser activated corneal adhesive to try to overcome this clinical challenge. Now chitosan is essentially derived from crustacean shells. Chitosan is a type of polysaccharide. Other examples of polysaccharide include starch, cellulose, glycogen, etc. We make this chitosan into a very, very thin film, and this thin film can be directly applied onto the corneal surface, and using a low-powered infrared laser, we can activate the stickiness of this patch onto the cornea. Now, several symposiums ago, we reported on our experience of using this technology to seal full thickness corneal laceration in a ex vivo bovine model. From that study, we were able to generate a burst pressure of up to 240 millimeter mercury, and our negative control group is only 36. Now, negative control group at that point was self-seal. Now, we use burst pressure because we're using burst pressure to quantify the degree of wound sealing, to give you actual number of how strong the wound is. So having that success, we thought it's time for us to move on to a in vivo live animal healing model to further assess this chitosan technology, hence my aims for this presentation. So we applied this chitosan adhesive in a live rabbit model. Here's our methodology. The 105 eyes. We created 2 millimeter lacerations or incisions on the right eye of all these rabbits, and then we divided them into 3 groups. The treatment group received the chitosan adhesive that we just talked about, activated with the laser. The picture over here, if you can see, that's the patch being applied onto the corneal surface, and the picture right next to it is the infrared laser used to trigger the adhesion of the patch onto the surface of the eye. Our positive control group received a single 1009 suture to close the wound. Now, negative control group is just 2 millimeter wound left to self-seal. Now, I have to say, all these 3 groups, we applied bandage contact lens onto the surface of the eye of all the rabbits, and they all received tarsorrhaphy. Now, these are done for comfort and to prevent these bunnies from removing sutures and stuff from there, further damaging the eye, essentially. So after the procedure, at fixed time points or up to 14 days, we select 5, or we'll take 5 rabbits from the group. We'll have them euthanized, unfortunately, and we do burst pressure testing on these wounds that's been sealed. And this is the data we derived. So having a look here, you can see the green line on top. That is the average burst pressure generated from our chitosan adhesive. It is very high from the outset all the way to the end of the study. The asterisk you can see on the screen, it just implies the statistical significant difference between the 3 groups. So we got the chitosan, we got a suture, and we got the self-seal. As you can see, by the time you get to day 7, day 14, the burst pressure is essentially no difference. Essentially, the burst pressure is 360. Now, 360 millimeter mercury is the maximum our study allow us to go to. We can't go anything above that. So based on these results, we can conclude that, oops, sorry, it's not letting me. Okay, so based on this result, we can conclude that this chitosan adhesive is able to adhere to the corneal surface of these rabbits and tolerate really, really high burst pressure. Now, looking at the numbers, if we say numbers implies, quantitatively implies the wound strength, we can say that the chitosan adhesive probably accelerated healing. But because healing, we got to assess more histologically, so we have another part of the study that we're going to look further into the histology of it. Now, as this study is also for a compatibility study, we can also say this rabbits having this chitosan adhesive attached to the corneal surface is biocompatible. We have a modified McDonald-Sherlock score, which we didn't really discuss in this short presentation, but will be in the main paper when we push the paper out. So yeah, it's a quick and easy corneal sealant that we've been working on.
Thank you very much. Any questions?
I've got a question, Jackie. Thanks for the talk. I enjoyed it. What are the optical qualities of the sealant?
Yeah, so the chitosan adhesive contains green, so it's slightly translucent green. I mean, I haven't really tried to look through it, but it's relatively clear. It's sort of a tinge of green to assist the operator to put onto the corneal surface. But yeah, it's not completely transparent because it's tinged.
Yeah, okay. And presumably that also assists the laser uptake as well, right?
That's right, yeah. The ICG traps the laser.
Yeah. Good. And how quickly is it kind of gotten rid of? Or
got rid of.
So is it do we know whether it's absorbed or are you left with some sort of corneal deposit, or what's the story?
Oh, you mean the adhesion, the chitosan patch on the cornea? Yeah. Yeah, so the chitosan essentially is biodegradable, so it breaks down over time. My previous coworker has got data on that, so essentially the tear just breaks it down and disappears.
Yeah, okay, thank you.
I have a question.
Sure.
Oh, sorry, I'm not sure if my video is on here, but oh, it's not. Okay, that's all right. I know that chitosan matrices are often combined with proteoglycans in the same matrix so that they can sequester and have growth factors added to that, which of course have been implicated in corneal wound healing. Have you thought about having proteoglycans combined into this matrix?
Not in my section. Is that Taylor? I recognize that.
That is me.
Taylor, hi Taylor. Yeah, absolutely. Chitosan is a very, very versatile polymer. You can do so much things with it. You can have it in liquid form, solid form. Yes, and I've heard of people applying molecules attached to it. So my previous coworker has incorporated vancomycin into chitosan as a form of delivering antibiotics over wound healing. I'm not so sure about proteoglycan. I assuming you're talking about polymers form.
Yeah, as in basic people. I was just reading a paper that came out at the start of the year that was showing people who've developed a combined chitosan and proteoglycan matrices for wound healing. And it just seems like that would have been the perfect thing to add here.
Yeah, absolutely. Chitosan is so versatile, I have to say.
Yeah.
There's so many functional group along the backbones. You can add so much things to it. So for the purpose of my study, I'm more of a clinician. So I suppose that question would be really more targeted towards my secondary supervisor, who is the genius behind this molecule.
Cool to see it all at work.
That's true.
Okay, thank you very much, Jackie and Taylor. We do have a question from Adri in the Q&A. However, we don't have time to address it. So perhaps Adrian, you could message Jackie later on. So now we have our break time again. And please come back for our next session starting at 11:34. I guess we'll come a little bit, and we can come a few minutes earlier, so we can start on time. Thank you very much, everyone. First speaker of our final session is Ms. Taylor Wisha, Syndicam proteoglycans in mouse lens development. Taylor, you can share your screen now.
Fabulous.
Thank you.
Right, is that all working?
Yep.
Fantastic. Hi, I'm Taylor. I am at the University of Sydney, not so often at SafeSite, and I am more on the basic research side of things. So a little break from all the amazing clinical work that we've been seeing. So I am going to talk to you guys about Syndian proteoglycans in mouse lens development. So first, just to remind everybody a little bit about eye development. So of course, as the eye develops from embryonic days 9 through to 18, we have different stages of eye development, of course, starting with the placode induction. So this is the induction of the lens placode from the optic vesicle. Then by day 10, we have invagination of the lens pit, primary fiber differentiation, apologies, that's the wrong photo. And then finally, by day 14, we get secondary lens fiber differentiation. And of course, all of these different stages of lens development in vertebrates are regulated by diffusible growth factors in the ocular environment. So although we know a lot about how these growth factors control these events, what we don't know is exactly how they're traveling through the extracellular space, arriving precisely at their target and activating the signaling required for that specific event at the appropriate level. So more recent research has found that these molecules called proteoglycans are actually master regulators of growth factor signaling and dynamics in pretty much all sorts of tissues. And they control everything from acting as co-receptors for these growth factors. So they act as co-receptors for their binding, for signaling activation. They also can directly control cytoskeletal dynamics, interactions with matrix proteins, and of course, as they are best well known for, regulate the diffusion and gradients of growth factors within the extracellular matrix, and of course, within the ocular environment. So just a little bit of background on proteoglycans. They are complex glycoproteins made up of a core protein and attached these glycosaminoglycan chains. And we're particularly interested in heparin sulfate proteoglycans, which have been shown in multiple systems to have a really important role in regulating both the localization and activation of growth factor signaling. So the thing about proteoglycans, and in particular heparin sulfate proteoglycans, is there's a few different types of them. So these different types are regulated by which core protein they have. So there are a few different classes. There are the syndicins and glyphigins on the cell surface, and then there are the well-known matrix proteoglycans such as perlecan, agrin, and collagen 18. So we were really interested in the syndicins here. So these syndicins are cell surface proteoglycans, and they've been shown in other systems, including in the lens, to regulate both growth factor signaling from a number of growth factors, including FGF, which we know is really important in the regulation of the lens, and also integrin signaling, which is really important for, of course, migration, all sorts of matrix interactions. So we were really interested in which of these proteoglycans were expressed in the lens. And because the profile of proteoglycans expressed by a tissue is specific to that tissue and even to the level of a cell type, we were really interested in which of these proteoglycans were expressed by lens cells, and if those proteoglycans and the proteoglycan profile of this tissue changed over the course of development. Because of course that would give us an idea of how different proteoglycans might be regulating the events that we know and love in lens development. So the first thing we did was have a look at the gene or the transcript levels of all the different proteoglycans and see which ones might be high. And the first thing we noticed from looking through some transcriptome databases were that these syndicins were in fact enriched in the lens relative to other tissues in the body. So this is just a chart looking at the whole embryo body and then the lens relative to that. So these show that most of the syndicins, in fact all of them, are quite enriched in the lens, and that they seem to be expressed differently at different stages of development. So this is from day 10 of development right through to day 0, so that's when they're born. So we were interested, are these syndicins differentially localized in the lens during development, and how? So we sectioned eyes from day 9.5 of development through to day 14. This covers all the main stages of lens development, being placoid induction, invagination, primary fiber differentiation, and secondary fiber differentiation. And through sectioning these, we then labeled immunofluorescently for each of the 4 syndicin proteins. So we found that syndicin 1 was actually not expressed early on, but later it seemed to become further expressed in the lens capsule and was not particularly strongly expressed in the rest of the lens. However, syndicin 2 was very strong both in the early stages of lens development, coming up very strongly in the primary fiber cells as they differentiate. And then very interestingly, as we get into the later stages of lens development, we have this really gorgeous nuclear label for syndicin 2, which is throughout the lens fiber cells.
Okay, Taylor, I think you're over time, so you are automatically muted.
Sorry.
I guess we will.
That's pretty much, it's nearly finished.
Sure. So it's a Q&A time now. But
of course.
Yeah.
That's pretty much all the results anyway. So
I guess I have a question. So just to follow up on that, and what are your main conclusions?
Yeah. So our main conclusions are just that so what we found is that the syndicins, all 4 syndicins are differentially expressed at different stages of lens development, which would imply that that the lens and also other tissues in the eye acquire specific profiles of these proteoglycans over different stages in development as the different growth factors are regulated. And this shows that these different proteoglycans are likely regulating different aspects of growth factor distribution in lens development.
I've got a question.
Yeah.
Do you have any hint of which growth factors or FGFs are correlating to the patterns that you found here?
Yeah, so that's something that we have to look into further. We know from some functional studies we've done that these proteoglycans are absolutely regulating FGF. Other studies would suggest that they are really important regulators of Wnt and BMP signaling, both of which, of course, we know are really important in eye development. So the problem with these guys is that they actually do regulate a lot of growth factors, not all of them, but many that are really important in both developmentally and postnatally in the lens. So I think what it's going to come down to is actually knocking out individual syndicin core proteins and seeing how that affects the phenotype, and maybe that'll give us a better idea.
Yeah. Good job, thanks.
Thank you.
Question from Paul. what do you think? What do you think is the significance of the nuclear localization of Syndicam-2 RE14.5?
Right. So that was actually super interesting. This is not the first time that Syndicam has been reported in the nucleus, but it is the first time that Syndicam-2 has been reported in the nucleus. When this has been reported previously, the reason which has been found for that is that it actually is important in translocating the growth factor along with the receptor to the nucleus for transcription purposes. Yeah, so we think that likely this is involving the differentiation and the cell cycle exit with Syndicam-2 and FGF, which is what has previously been shown to be associated with nuclear localization of Syndicams.
Thank you very much, Taylor. The Q&A session time's up. So let's move to the next presenter, Mr. Charlie Song. His topic is development of a collagen-based bio-ink for wound healing and 3D bioprinting. Over to you, Charlie.
So just try to unmute myself. Yeah.
We can hear you now.
Okay, so can you see my share screen? Okay. So hello everyone. So I'm Charlie, a third year PhD student. So my project is developing a printable collagen ink for corneal wound treatment and 3D printing. So first, it's a short introduction. So my ink is collagen type 1 base. So collagen type 1 is a major component of corneal stroma. It's about 70% dry weight of the corneal stroma. So the cross-linking method I use is photo cross-linking. So I use riboflavin as a cross-linker and use UV to activate it. So during the cross-linking process, other additives like growth factors and even cells can be added into the collagen ink and be printed out together with the collagen ink. Then I use UVA to activate the cross-linking and cross-link the collagen ink to a solid collagen gel. So, so the applications of my collagen ink is treating corneal ulcers and perforation, and it can also be used as a drug or cell carrier and for 3D bioprinting. So like in the past symposiums, so I present some features of my collagen ink, which I already showed that it's printable, and the cross-linking the cross-linking light, which is 365 UV at 3 milliwatt per centimeter square power. So it's widely used in the clinic and it's safe for the eye. And I also demonstrate that the cross-link collagen ink is transparent, which has 90% of transmittance for the light in a visible range. So I also demonstrated that the cell, so my collagen ink is cell compatible, which I can encapsulate the stroma cells in it and culture epithelial cells on top. So recently, so I did experiments about sealing the small perforation of a cornea and fill non-perforating wound. So according to my experiment results, so my collagen ink can seal a small perforation which has a diameter of 1 millimeter, and it can stand up to 50 millimeter mercury pressure, and it's not like bursting. So about the wound filling, so my collagen ink can fill the wound up to 4 millimeter in 4 millimeter diameter, and I wash it under running water for 1 minute, and it still stay in the wound. So I also did 3D printing. So just 2 weeks ago. So we have successfully printed out, so I can say it's a bioengineered corneal stroma. So at this stage, it don't contain any cells. It's just the collagen 1 ink. So I used a 3D printer provided by our collaborator at the University of Wollongong, and under the blue light for cross-linking. So so at the end, we have like a transparent structure, which has the corneal shape, and actually we can change the diameter of this structure to fit. Like if we're going to use this to the patients, we can actually customize it, like change the diameter, change the thickness, make it to fit different patients. So my future experiments for this project will be I'll do some experiment to demonstrate its cell carrying ability and like the gel carrying ability, and the long-term cell interactions is still need to be investigated to see like if the cells will change the structure of the collagen gel. Okay, I would like to thank my supervisors, my colleagues, and our collaborators at the University of Wollongong. Yeah.
Thank you, Charlie. Any questions? Okay, one question from Adrian. Without embedded keratocytes, will it degrade?
So it won't degrade without the keratocytes or other things embedded in. I think I found it like it's stable in PBS for more than half a year. So in the fridge. So I think it's like very stable.
I've got a question, if that's okay. Thanks for the talk. In terms of its sort of optical qualities, how's the collagen kind of laid down when it's printed, and why is it still translucent?
Translucent? Oh, yeah, because the collagen contains some cross-linkers, so it will be like a bit translucent and yellow in the beginning, but later after we put the printed structure into the PBS for washing, I think for only like for a very thin structure, like only with 15 minutes of washing, it will be like very transparent.
What I'm getting at is, do we know like anything about its sort of crystalline ordering? So we know quite a bit about why the corneal stroma is clear, but yes. Do we know yet with the bioprinted collagen why it's transparent?
Yeah, so I think it's because the collagen fibers packed together. So the distance between the collagen fibers is so I'm not sure. So I think it's the distance between collagen fibers is the important factor to let the whole structure transparent. So it should be smaller than the wavelength of the visible light.
Yeah.
Also, if I remember correctly.
But we do know that for the bioprinted. It's just a general question.
Yeah.
Do we know that to be well? Presumably, it is the case.
We don't know. I'm actually doing SEM imaging of the bioprinting collagen to see if it has this feature, but I'm still waiting for the image. So we did that at University of Wollongong.
Yeah, thank you.
Charlie, it's Jack. Oh, sorry.
All right, go ahead.
Taylor, you go. Ladies first.
Quick question. How thick are you printing this gel relative to the thickness of the actual cornea?
You mean the thickness of the gel?
Yeah.
Okay, so the thickness is around 400 micron to 500 micron. I think which is similar to the thickness of the corneal stroma. Layer.
And if cells were to grow into that, on the places where you're adding that, would you just add that on the place that there was a wound, or would you add that on top of the whole cornea?
You mean the printed structure? Actually, so So for the bioprinting, actually, I'm trying to print a whole cornea structure. It's not like added to the cornea. So I try to print something that can replace the cornea. It's for bioprinting.
I think what Taylor means is if you incorporate cells in your structure and print it, or you print the structure and then you add cells to the top for wound healing. Am I right, Taylor?
Oh no, my concern was more if you added this on top of a wound, if that would increase the thickness of the cornea and then cause some aberration in terms of focusing of light.
Yeah. So when doing a wound sealing or healing, I will just inject a very small amount to the wound to seal it or to fill it. So I don't think it will like make the cornea thicker or something.
Okay, interesting. Thank you.
Kelly is Jack, if you're still able to take more questions. I'm also working on a similar concept as you, but I can see a lot of application coming up from your BioInk. Amazing work. I saw you guys using this collagen to fill defects, and you also talk about sealing full thickness corneal wounds. Is the primary objective to fill defects, or are they actually designed to seal full thickness wounds at this point?
I think the main function of my collagen ink is to do the bioprinting, but sealing is also a part of its function. But now we haven't like investigate like very deep in that field about sealing a wound. We just do some we just complete some like very simple experiments in our lab to demonstrate that it can seal the wound and stand at up to 50 millimeter mercury pressure. And I think that's all we did.
Okay. Would you guys be considering making the wound a bit bigger? Because you talk about 1 millimeter wound.
Sorry, I have to interfere as the time's up. But again, use the chat channel, maybe private chat channel, and to discuss this. So after the meeting, you can ask Charlie more questions. So our next presenter is Miss Pauline Koo. And her topic is signs and symptoms of dry eye in aromatase inhibitor patients.
Thank you, Jingjing. So I just want you all to imagine you were taking a drug that was saving your life, yet at the same time causing a debilitating condition that was treatable but went undiagnosed. Now, this is something that millions of women go through every day with breast cancer, and this condition is dry eye. So 1 in 8 women is expected to develop breast cancer in their lifetime, and aromatase inhibitor, which I'm going to refer to as AI throughout this presentation, the first line of treatment for breast cancer in postmenopausal women. And that means in the foreseeable future, we're likely to see millions of women using AI therapy. Now, recent studies have shown an association between dry eye and AI use, and they've found an increase in prevalence of dry eye in AI patients compared to healthy postmenopausal women. Now, dry eye occurs where the eyes don't produce enough tears or produce low quality tears, and it can often lead to a burning sensation, redness, watery eyes, and even blurred vision. And this is a really big cause of concern, as AI side effects are strongly associated with treatment non-compliance, which can actually increase the risk of relapse. So the problem that we face is that the association between dry eye and AI use has only been shown via dry eye questionnaires, and little is known of the effects on the ocular surface. So the aim of this study was to test whether symptomatic dry eye in AI patients is associated with clinical features of evaporative dry eye. So it was a cross-sectional single visit observational study of postmenopausal women treated with AI therapy. And patients were recruited from the Post Center, Prince of Wales private and public hospitals, and all clinical assessments performed at the SafeSight Institute. So during the clinical visit to the SafeSight Institute, we collected the following data. So patient history, which included patient demographics and medical history. We performed the Ocular Surface Disease Index and speed questionnaires, which are questionnaires that assess for dry eye symptoms. And we also performed a number of dry eye examinations and captured images using the ocular keratograph. We then assigned patients to either being symptomatic or asymptomatic, depending on their Ocular Surface Disease Index score. And any patient with a score of 13 or more was considered symptomatic. So we recruited a total of 25 patients, 16 were symptomatic, 9 were asymptomatic. And just on this slide, the red will represent symptomatic patients and the blue will represent asymptomatic patients. So the mean age for the entire cohort was 62 years, which was similar across both groups. The mean duration of AI use was longer in the symptomatic group of 41 months compared to 27 months in the asymptomatic group, but this was not statistically significant. We did see a huge difference actually with the ocular surface disease index score, but we expected this as patients were assigned according to this variable. And we also saw a significant difference with the speed score, with the symptomatic group having a score of 11 compared to 6 in the asymptomatic group. So for the clinical assessments, we included both eyes in the analysis. And across both groups, the results are pretty similar, except for T osmolarity and meibomian glands dropouts. We saw significantly higher T osmolarity in the symptomatic group, and it was within range of what's considered mild to moderate dry eye, as opposed to the symptomatic group that was considered normal. We also saw increased meibomian glands dropout in the symptomatic group of a score of 4 compared to 1 in the asymptomatic group. Now, we also know that dry eye signs and symptoms are poorly associated. Therefore, it's not unexpected that we saw the non-invasive T breakup time to not be reflected in our patient group. We saw significantly higher non-invasive T breakup time in the symptomatic group compared to the asymptomatic group. And there are two possible explanations for this. So firstly, the method of examination via the non-invasive T breakup time using the keratograph actually induces mild reflex tearing due to the forced eye opening required during the examination. And a possible another explanation is actually patients with meibomian glands dysfunction actually have increased tear secretion to compensate for the loss of meibomian glands. And this is supported in our study as majority of the symptomatic patients had severe meibomian gland dropout. We also performed a binary logistic analysis to determine the likelihood of a patient experiencing dry eye symptoms. And we found out that patients with longer duration of AI use and also higher T osmolarity had an increased likelihood of experiencing dry eye symptoms. So just to sum it all up, AI patients with symptomatic dry eye have higher T osmolarity and increased meibomian glands dropout. Patients using AI, usually their meibomian glands are impacted. Longer duration of AI use increases the likelihood of a patient experiencing dry eye symptoms. And so for clinicians who are treating patients who are using AI therapy, management should actually be focused on improving the meibomian glands function. Thank you for listening. And I'll just, I guess, open the floor if anyone has any questions.
Thank you. Question time. It's good to know that the AI now has another definition to it.
Yeah, I realized it could have been a little bit confusing.
Is there any questions?
Good question from me, if you don't mind.
Sure.
Did you guys perform any neuroimaging or immunoimaging?
No, not neuroimaging. So the keratograph only does more ocular surface, so it was all focused on the cornea and more just around the front of the eye.
Let me rephrase. You can take images of the nerves of the cornea.
No, we did not do that. But we did actually perform, so we performed a questionnaire that was designed for endocrine symptoms, so patients going through cancer treatments. And it was to determine if they were sort of feeling any pains. So specifically, we weren't really looking at their pain symptoms, if that's what you're referring to in terms of the nerve. But we didn't really see much of a difference in terms of that.
And immune imaging, any differences between the immune?
No, we didn't actually do images on that either.
And for anyone who's not sure who was the person asking the question, that was Yasha. Any other questions?
I should have introduced myself.
Okay, we have a hand up. So Jackie
Hi,
wants
Pauline.
to ask a question.
Hi.
Hi, Pauline. Now that your study suggests the meibomian gland being the main culprit for AI used dry eye, has there any trial treatment using so more hydrophobic types of eye drops for this sort of symptoms?
In this particular cohort of patients, or in terms of meibomian glands dysfunction?
That and also this group of AI patients.
No, so in terms of, it's been kind of recent in terms of identifying that aromatase inhibitors actually affect the meibomian glands. A lot of the studies, like I mentioned, only use dry eye questionnaires, so they weren't even sure what part of the eye was actually getting impacted in this. So we were one of the first studies to actually identify that the meibomian glands impacted. So in saying that, we did also look at blood analysis. So obviously based on the 5 minutes, it's kind of limited with time, but we did look at blood analysis to determine, you know, is that making a difference? And we also looked at tears. In this particular group of patients, obviously because they're using aromatase inhibitors, it actually reduces the estrogen level within their serum levels. But I think we actually need to look at a control group. So just before COVID hit, I got approval to actually do the study in control patients. So I was going to do it in healthy postmenopausal women to determine if their serum levels also quite similar, whether we are seeing low levels of estrogen or whether it's just normal, because that might actually give us answers in terms of what's happening in this patient group.
Mm-hmm.
Thank you very much. So the Q&A time's up. Thank you, Pauline. And our next speaker is Mrs. Nicole Helen, deep learning-based unsupervised and semi-supervised classification for keratoconus. Over to you, Nicole.
Thanks, Jingjing. I'm just trying to get my slides up. I've got some NBN dramas going on here, so please bear with me. Okay, good. So I'm talking about completely different AI to Pauline. I'm going to give you a snapshot of my PhD project, and today I'm going to talk you through my approach to using machine learning to work towards keratoconus progression. And huge thank you to my phenomenal supervision team of Jared, Jingjing, and Chris. So as we've all seen numerous keratoconus presentations, I won't spend my time today on the disease mechanics, but rather will outline the aspects that are most relevant to my research. So with keratoconus patients, we know that there is a complex matrix of risk factors that range from things like ethnicity, gender, genetics, weight, atopy, age, other disease presence, and things through to eye rubbing. And there's no broad consensus on which of these risk factors contribute the most to keratoconus. What makes the disease so difficult to both classify and to accurately predict any kind of progression is that there's a combination of these risk factors, and how they affect each patient is extremely differentiated. So also, one of the key things that is a real issue is that it's a multifactorial and degenerative disease. And so it's absolutely vital that we have a really good framework to better understand the likelihood of disease progression so that we can better optimize our surgical preventative interventions, such as corneal collagen cross-linking. So one of the key challenges is that there's no broadly agreed consensus or classification system for keratoconus. We know that patient progression is extremely variable. We might see a 17-year-old patient who really never progresses beyond the original diagnosis, whilst we might see a 14-year-old who actually needs keratoplasty with only a few years of diagnosis. So given this variability, determining optimal surgical intervention is vital. And as there's no yet agreed prediction model, it presents a huge challenge for optimizing our surgical intervention. So our concept has been to take a range of readily available clinical and patient data that's already collected from keratoconus patients and develop a machine learning model to help with the challenge of classifying patients and therefore being able to work towards a model of accurately predicting disease progression. So we've utilised data that was retrospectively collected from Vision Eye Institute in Chatswood between 2014 and 2017. It's a single centre study, and it comprises of 124 keratoconic patients, 64% of whom are male and 36% female. And the objectives for this part of my PhD project were to use supervised and unsupervised models to classify different stages of keratoconus, and then to compare the accuracy of the supervised versus the unsupervised model in this classification task. So we developed two models that work together in essence. Firstly, a semi-supervised multi-layer perceptron model, which is a fully connected deep neural network, which we use to classify the patients with reference to the Amsler-Krumrich classification, and then an unsupervised variational autoencoder with a Gaussian mixture classifier to cluster our patients. And so there's an image of the MLP model at the top and then the VAE model at the bottom. So as you can see, I'm now using a prototype whereby I'm able to select one of my patients, in this case, patient number 10, who's a 33-year-old male. And I can see, it's a bit difficult to see on the screen, but I can see where he sits in my cluster of patients. And what that allows me to do is see if this particular patient moves around in the classification of keratoconus when they come in for their ophthalmic visits. So in terms of looking at the results, the multi-layer perceptron model, which was our three-layered fully connected deep neural network, we broke it into 72% of the data for training, 18% for validation, and 10% for testing. The average accuracy of the classification here was 73.9%, with our area under the curve values of 0.92, 0.86, 0.83, and 0.91 for classes 1, 2, 3, and 4 respectively. And that's really promising because with AUC, we know that the closer to 1 we get, the more accurate we are. With our variational autoencoder, we utilise the latent 2D features of our vectors of the corneal input data, and we were able to cluster our patients into 4 classes with an average accuracy of 80.3%. And in this case, the ROC curves for classes 1, 2, 3, and 4 achieved 0.91, 0.87, 0.79, and 0.99 respectively as well. What we did find was that the unsupervised model, as you can see, when we compare 80.3 to 73.9%, achieved higher results. And if you'd like any more information on the actual results, we've recently had a paper published, which is provided on the bottom of the screen for you. So in terms of our next steps, continuing to train, test, and optimize the model. We're working with a number of centres externally to the ones that we've used to try to enhance the data volume and variability. With artificial intelligence, data is always the key issue. Also working on rationalising and testing the variable inputs. Really exciting project and super keen to undertake the next steps and see the model progress further. Finished.
Thank you very much, Nicole. Question time.
Yay.
I've got a question, if that's all right. What's the overall performance if you just break it down into keratoconus versus non-keratoconus?
We are testing that at the moment. I guess one of the issues is most of the models that have been used in the market to date are analysing images. So they're taking scans from Pentacam and diagnosing between disease versus non-disease. And interestingly, most of the models to date have looked at a subclinical keratoconic eye as compared to an existing keratoconus patient. So we can distinguish, and we've been doing some random forest testing. We can get to about 93, 94% accuracy at the moment, but we're focusing more on the VAE model to date, but it's certainly something we're looking at. Does that answer your question enough?
Yeah. What are you defining as accuracy?
In terms of the statistical accuracy and also the AOC and ROC.
Yeah, okay.
Could I ask a question? It's Peter McCluskey.
Hi, Peter.
Yeah, can with your 4 different stages or classes, are you hoping, do they predict anything, or are they severity markers? What do those classes represent?
So we let the model with all of the data we put in, because at the moment we all know that different clinicians use different models for classification. So what we did specifically with the unsupervised model that's really interesting is we allowed it to cluster patients itself, and it did that with 80.3% accuracy compared to our Zacrymic. So the real issue here is that we would hope that if you were to see a patient, we put them in the model, it classifies them into one of those 4 classes that the model determines are important, and then you're able to track that patient, which is what I'm trying to get across with that with the prototype, in that you can see if that person's moving closer to the next class when they come in and see you next time. So you're able to work out whether the disease progression hopefully has progressed to the next level.
So the classes represent disease progression?
Well, they represent, current severity classification across a range of variables. And the idea being that we would hopefully, as we refine the model and put more data in and test it with a broader centre data, that we're able to then work out whether your patient is actually moving between, say, class 1 and 2. You would then start to look at, some sort of intervention.
Yep, got it. Thank you.
There is a question in the chat. Any reason why more recent grading systems such as ABCD was not used? And that's a question from Hima Kendall.
Look, I think we could have put it against many different classification models, but in terms of the clinicians that I'm working with, and in terms of, I guess, comparing against a number of papers that are in the reference material already, AK was most commonly used. A lot of groups look at the specific data, such as the Bell-Ambrosia Index, which is related to Pentacam. What we wanted to do was try to come up with a model that is not necessarily linked to one specific device, so that it has broader application across clinicians, not just those who use a specific Pentacam device.
Okay, thank you, Nicole. And the time's up. Our next speaker is Miss Annette Hosking, and her topic is fireworks-related eye injuries.
Great, thanks so much for the opportunity to talk today. Let's check that you're seeing my screen okay. You should be seeing my presentation.
Yep.
Perfect, thank you. Okay, so as has already been said, I'm going to talk about fireworks-related eye injuries, which was one of the projects that I'm working on as part of my PhD. And I guess ocular trauma broadly is the topic that I'm looking at and how we can prevent it. And I live in Western Australia, so I just wanted to show you this lovely image of wildflowers in Western Australia at the moment, but just again to highlight the immediate and devastating impact that ocular trauma can potentially have. And the fact that we go from lights on to lights off very quickly, it's something for the patients, which I'm sure you're all aware of, is extraordinarily devastating. And for fireworks in particular, it's a really important topic. In Australia, fortunately, we're very lucky to be able to not see that many fireworks-related eye injuries, but in many other countries, it's a huge issue. And so for this study, it was really about the power of collaboration and using a platform that we've developed to try and collect data specifically on fireworks-related eye injuries. And then I just want to focus a little bit at the end about some of the prevention strategies and future work that we might do. So the International Globe and Adnexal Trauma Epidemiological Study, as it's called, we collected data from 4 different countries. And as you'd imagine, trying to collect data from a number of countries with a number of different collaborators is extraordinarily time consuming, but we were able to successfully collect data from those 4 countries, and we had 388 patients with 474 eye injuries, and a huge proportion of those ended up with some form of vision loss in their eyes, and almost 1 in 5 of them had severe vision loss. So fireworks can be a really devastating cause of eye injury, and particularly you see more bilateral eye injury, which again, you know, is even more devastating. So as with lots of other types of eye injury, boys are more represented in the data, but with fireworks, children and bystanders as well often pop up in the data, and you know, it's something to be aware of. And you know, again, in Australia, it's not something that we need to really worry about because we have such strong legislation, but in many other countries, particularly countries like India, China, Nepal, and the Netherlands, that you'll see it's a huge problem. So in terms of preventing fireworks related eye injuries, I like to use this little inverted triangle that shows you the sorts of things that we can do to help reduce the impact of eye injuries from fireworks. And really in this context, we're working with a lot of cultural and social constructs that people use fireworks for so many different things that it's really hard to eliminate them. So for those of us old enough to know about Guy Fawkes and, you know, the different fireworks festivals that we used to have in Australia, you know, I think the public health community and ophthalmologists in particular were really effective in promoting the need for legislation. And as I said before, that's been very effective. And that elimination is really one of the most effective ways of doing it. But of course, there's other ways that you can prevent these sorts of eye injuries or prevent the hazards, you know, using substitutes like drones to create fireworks displays, having engineering controls or administrative controls. And then the last one is around eye protection, which you see very minimally in fireworks, and certainly in our data set there was a small handful of people that were wearing eye protection. But despite the use of legislation, we still see fireworks eye injuries, and certainly in Australia we have a very limited number, but most of those occur in the Northern Territory. And they have a small 24-hour window where people are able to use fireworks, excuse me, and we, as you can see from this news article, see eye injuries from that. And as I said before, the visual outcomes are quite poor for this type of ocular trauma. And for a large percentage of those people that were affected, they had some kind of vision loss, if not severe vision loss. You can see there the different types of injuries that people had. And just again, going back to campaigns in the Netherlands, so one of our collaborators, they've been very effective at campaigns, and even something as simple as reducing the number of hours that people are allowed to use fireworks from 16 to 8, saw a reduction in the number of eye injuries. So all of these things can be looked at, and really, you know, we all have a role to play in terms of this prevention, even though in Australia we have this fairly strict legislation. It's something we need to continue.
Okay, thank you, Anna. I think you over time, so it's automatically muted. Any questions for Anna? I have a quick question. So when you're looking at different countries that are still suffering by work injury traumas, do you see differences in terms of, so first of all, do they all showed a trend of reduction in recent years? And do you see differences in terms of what sort of strategy may be more relevant to certain country? Any country-specific variations there?
So certainly there, we only saw that, I mean, our data didn't go over a long period of time, so we weren't able to determine any change. We're really just looking at key periods of fireworks-related eye injury. But certainly for countries like India, as I was saying, because it's so strongly linked to their social and their social activities, it's something that is really hard to mitigate against. But what we've seen that's been most successful in a country like India is the fact that they're now promoting reduced use of fireworks. And it's not because of the eye injuries, but actually because of the air pollution. And I think this is a really important factor that, you know, we shouldn't discount the fact that there might be other factors that have a role in promoting prevention and reduction. And the other one, I know in parts of the US, they've been very successful, even though we don't have US data, but looking at other data that's been published, they've been very successful in incorporating animal rights advocacy into fireworks prevention measures because of the distress and injury that it causes to animals, you know, associated with fireworks. So a bit of a mixed answer, I guess, in terms of the different approaches in different countries, and it's really got to be what works. And again, you know, we're just very fortunate that in Australia we were able to get on top of this very quickly.
Thank you very much. So let's move to our next presenter and also our last presenter for the last student presentation for the symposium, and that's from Dr. James Mabley, evaluating severity of microbial keratosis using optical coherence tomography. So, over to you, James. Okay.
Okay, can you see my screen and hear me? No. Okay.
Yes.
Can you see my screen now?
Yes.
Okay. Okay, sorry, just getting set up here. My name is James Maberly. I'm going to be giving a talk today about evaluating microbial keratitis using an imaging modality which is called optical coherence tomography. So bacterial keratitis is an infection of the cornea, and it's caused by non-viral pathogens. It starts with contamination of the epithelial layer it starts with epithelial layer of the cornea and progresses to proliferation of the organism. So the epithelial defect can form as part of the proliferation of the bacteria, or it can be a substrate of which the bacteria holds onto. It can lead to corneal scarring, perforation, rupture, and it can cause visual defects and affect quality of life. The most common pathogens are Pseudomonas aeruginosa, Staphylococcus epidermidis, and Streptococcus pneumoniae. It's possible to get fungi, both filamentous and yeast, it's more the fungal infections are more common in the agricultural settings and humid climates. So it's also can be rarely in acanthamoeba, which is a protozoa. So in industrial nations, it's usually related to contact lens wearing or elderly patients, excuse me, which have an underlying ocular surface defect. Early diagnosis is important and crucial for treatment. So the optical coherence tomography is an imaging modality which utilizes optic waves, similar in that ultrasounds use to create an image, except they use a reflection of the photon off the tissue and reflect back and generate an image. It's a non-touch technique, which has an advantage in the ophthalmology area because it reduces risk of contamination and bacteria, introducing bacteria. It's used commonly for retinal imaging and is more commonly now being used for anterior chamber in studies such as glaucoma, where you're looking at the angles. So it's relatively new to the corneal imaging field. However, there have been lots of developments recently with the improvement of the optical coherence tomography technology, allowing for higher resolution imaging, which allows for more detailed analysis of the substrate of the cornea or the makeup of the cornea, allowing for identification of epithelial defects and characteristics that of progression of the keratitis. So the study design is about analyzing the severity of microbial keratitis using optical coherence tomography. And the way this was done is using an evaluation tool, which I'll get into in a little bit. And the purpose was to assess how we screen and potentially have an impact on treatment down the line. So the method involved recruitment of 68 eyes from Sydney Eye Hospital from 2016 to 2018. These were patients that had a clinical suspicion for bacterial keratitis, and they were worked up by the ophthalmologist and then linked into the study with a screen on their day of presentation, a scan of their eyes using OCT on day 0, day 3, and day 6. The evaluation tool, which is there on the slide on the right, which is a table which categorizes each specific parameter and gives it a point scoring system. This evaluation tool was adapted from an existing tool which is used for slit lamp analysis, which is currently used around the world using slit lamp to score severity. The addition or the modification in this tool was to involve the epithelial defect or ED area dimensions and also the corneal thickness percentage, which relates to the thinning percent of the corneal over the defect. the results show that the patients who required surgery had significantly higher score using the evaluation tool than those that resolved, meaning had no further evidence of any defect, corneal thinning, stromal infiltrate. They reached complete resolution without any further intervention. So the difference between those was showed a significant difference of 0.042, and the study essentially showed that you can use a tool like this. You can use OCT to supplement your evaluation technique to get a prediction on the severity or the outcome of the progressive microbial keratitis. The implications being that you could use it to tailor your.
Okay, thank you, James. Your 5 minutes up. All right. Any questions for James?
I have a couple, if I may.
Yes, go ahead, Yasha.
So in terms of what you, for your patients, you mentioned basically aligning with surgery, that the percent was, that you were looking at that. Was there no treatment done prior to in any of these eyes? Because I'd assume that first you would confirm that indeed it is a bacterial infection. You would do swabs.
James, you need to unmute. So
Yeah, sorry.
Yeah.
Yeah, sorry. So the surgical outcome was. Can you hear me? Sorry.
Yes, we can hear you.
The surgical outcome was one potential outcome. All the patients were swabbed, so they followed the regular procedure where they were seen in ED. They had a regular swab, and which was followed up when the swab came back. And I've got the statistics about how many actually came back with positive microbial keratitis in the swab. And I've also got some analysis based on the different bacteria and what the outcomes were. But only not many patients proceeded to surgery, but that was one potential outcome of the patients.
Thank you. Any other questions? What's interesting to see that you put machine learning in your future studies.
Yes.
So what's your plan of using machine learning on this application?
Well, I think this type of tool lends itself very well to machine learning. I think that you can tailor the tool to make it more effective and efficient using machine learning to sort of build the database and fine tune it so that you get very accurate predictions of outcomes. And ideally, you'd use it to differentiate different bacterial strains based on the pattern of progression through the cornea. So stromal thickness plus leukocytic infiltrates in certain areas would be more characteristic of a particular, like a Pseudomonas strain. And that would be much better elucidated through machine learning.
Thank you. Do you have any other questions for James? All right. Thank you, James. And now we will move to Dr. Sammy Lee to talk about career pathways in research. Okay, over to you, Sammy.
Okay, all right. Let me see if I can get this working. Yep. Okay. Sure. Okay. All right. Okay. Good afternoon, everyone. Thanks, Pauline and the organizing committee for inviting me to talk about my career and my experience in academia and industry so far. So I'll be talking briefly about my academic career and my recent jump to industry and how I got here and what key points I think are important in academic environment and how to search for your next job or role. So I want to talk about, okay, screen is paused. Oh, here we go. So I want to talk about my basic career path so far, and a bit about academia and industry, and then final remarks on what I think are important. So I started off my career doing a PhD at the University of Melbourne with Paul Newley, who is now at SafeSite Institute. And through their supervision, I completed my doctoral degree in a reasonable time. So it's important to have a good supervisor. And my takeaway from this experience was to publish papers and present as much as possible. As an academic, papers is what you are rated upon. So the more you publish, the better. You're basically laying down the foundations of your funding and everything associated with your academic career. So for a PhD student, your next phase would be to try and get a fellowship for your postdoc. So if you have papers as you're publishing in your PhD, then this allows you to apply for your fellowship or be highly rated for a fellowship. So that was something that I found was really important and was advised to me during my PhD. And having a fellowship is important because that allows you to work on things that you are interested in working in for your postdoc. Because you bring in your own money, you can choose the type of projects that you want to do. If you don't have your own money, then you're more restricted about the projects based upon what the PI or the lab head wants you to do. So my first postdoc was at University of California, Santa Barbara. And how I got there was, and how I picked this lab, I think this is important for people wondering how to find the first postdoc job, was through networks. So I asked my supervisors at the time, and I also asked other PIs and lab heads that I knew about things I was interested in and who they could suggest for me to contact. And I found Ben Reese's lab at Santa Barbara through the late Dick Marsden, Professor Dick Marsden, who had a sabbatical at our lab at the time, and he said, you're interested in developmental neurobiology, so how about you contact this lab and see if you fit. So my thesis was on bipolar cells and cone photoreceptors to bipolar cells. That was my thesis. And Ben and his lab at the time were looking at how bipolar cells were, the developmental growth of bipolar cells. They were just moving into that project. And so it was a great fit for both of us. I was interested in looking at development, and they were interested in hiring someone that had an expertise in bipolar cells. So finding the right interest and the right fit and was very important. And also found that his lab was very small. It was run like a family environment. So having a mentor that for your first job that was a bit more hands-on and can give you, I guess, more immediate advice was very useful for me. I found that there's some other labs that are quite big, but you might not get as much personal advice, but you might have a experienced postdoc guiding you rather than a PI, which is fine as well. It depends on how you want to work and how you operate. So I think it's important to find that lab that you want to work with and the interest aligns. Similarly, my next stop was at the Max Planck Institute in Germany. So how I arrived at this lab was presenting at a conference, and presenting at the conference, I was interested in looking for my next role, my next postdoc, and I found I was speaking to someone that had similar interest to me and similar work, that we were both kind of working a project that was quite similar and so we got talking and end up working over in Germany. So basically my point is that you have to network throughout your career. You have to go out and present your work and through these kind of interactions, you might find your next opportunity. You might find the next opportunity to either collaborate or your next job. And then after spending 2 years in Germany, I came back to Sydney to SafeSight Institute to work with Paul and Uli. And one of the reasons I came back was I found that they were working on human donor retinas, and this really intrigued me, interested me. So again, this comes back to I was comfortable with working with Paul and Uli, and the project and the things that they were working on was quite interesting to me. These kind of led my career choices, finding people that I was very comfortable working with and people who I could learn from, and also finding the right project that really interests me. And if you're working on something that you're not interested in, then I don't think you'll be that successful at it. So finding something that you're really interested in is key. I guess this is that's the end of my academic career, and I started working in a pharmaceutical biotech company called PH Pharma at the start of this year. And how I came about to working here, I was presenting at ARVO. Again, I was presenting at a conference, and people from this company saw my poster, and I was at this poster, I was talking about ganglion cells in the primate, and they were interested in looking for someone that had expertise in primates and in ganglion cells to work on a drug that they were developing for glaucoma. So our interests aligned. Initially, I thought that they were just going to send me the drug and have me work on testing this drug on our primate models. But turns out later, when we got to talking, they said, we're actually interested in hiring you and bringing you over. So through networking at a conference, somehow I landed my next job. So I guess in academia, I'm just going to talk a bit about academia, what I found important, and compare it in the next few slides to industry. So in academia, as I mentioned before, papers and presentations are very important. You get rated on your publications, how many publications and how significant those publications are. At every stage of your career, you're asked for how many publications you have published. Even in your early stage, before you finish your PhD, you need to publish, I think, before you can apply for your next job. And presentations allow you to network with other people that you can potentially collaborate with or work with in future. So I think going to conferences is very important throughout your academic career. Another thing that's important in academics is teaching and mentoring. So that is something that I won't go into that much detail, but that's an important part of academia. Now comparing to industry, it's a business. Industry is a business. So in industry, it's all about adding value or making money for the company. So one of the things I found that was different in academia research, positive results are what you're aiming to produce. Negative results is not as favorable because they can't use that to promote whatever their product is. And negative results is kind of like a loss in money in a way. So that's one of the differences I found in research between academia and industry. One of the benefits of working in academia, in industry, is that you are interacting with people outside of research. So you are talking to people that are not as like-minded. So you're not talking to researchers, you're talking to maybe lawyers, accountants, and business developers. So you have to be able to have, I guess, good interpersonal skills. And I think as a researcher, when you go out presenting at conferences, you develop that skill. But when industry people look at your CV, they might not understand that PhD graduates have these skills. They have leadership skills, interpersonal skills, and presentation skills, and writing skills. So it's important to point these things out when you are writing your CV or writing application to a job in industry. A lot of the skills that we learn in research is applicable to industry, I think, but you have to be aware about what industry is after and write your application and resume based on what you think they would want to hear and highlight your skills that you have. So I already talked about the slide. So one of the things that they valued, this company valued, and what I brought into this company was my expertise in ophthalmology and eye research. So when you finish your PhD and when you do your postdocs, you have to realize that you're one of the world experts in your field. So this is something that's highly valued when you go to industry. Another thing that they valued was my networks and contacts that I brought to the company. So because a lot of these people are business developers and accountants, they don't have that foothold into the research community. And so having someone like me can easily talk the science and reach out to people that can help us develop our products a little bit better. So one of the things that I'm working on right now is, as I mentioned earlier, is a glaucoma drug. And we want to test this glaucoma drug in animal models or in clinical trials. So they need someone like me to help design the experiment and then reach out to, if we can't do this experiment in-house, we're a small startup, so we need to contact universities and other institutions and partner with them to do these experiments. So we would fund their project and this project, and they would do this experiment for us. But the people in the company that are business developers, they might not know which labs are appropriate or who to contact. So this is something that I would bring to the company. And I think you need to highlight these kind of, I guess, these things that you have in your CV if you're applying to an industry job. It's not obvious sometimes. So I guess final word is that you know, examine what your motivations and interests are in your and your best environment for what you want to achieve, either in academia or industry. I think it applies to both. If you want to achieve a certain thing in academia, then you need to figure out how to get there and then how to achieve those goals based upon things that you need to do to get there. I think you need to build up a network in both academia and industry. And if you build up your network in academia through conferences or collaborations, that network that you build up would always be useful if you decide to go to industry. And you know, if you go to conferences and talk to other people, you always learn a bit more about other projects and what's outside your field. One of the things that I thought was very useful when talking to people at conferences was that it makes you realize that what you are doing is quite important. Sometimes you're so stuck in your own little world in research that you don't realize that other people around the world actually value what you, your research and what you're doing. And the next point is a bit more related to industry. So when you are applying for jobs, think about the skills that you have developed during your PhD and postdoc, and highlight those skills, because it's not obvious sometimes what a researcher, what skills has. They know that you have a particular skill set in the laboratory, but in the commercial world, they want to hear key points such as leadership, interpersonal skills, and commercial awareness. And these things, you might have the skills, but you need to point out and give examples of where you showed leadership. For example, you might have been leading a research project and how you led students or other staff to run this project. I mentioned interpersonal skills before. This is about networking. So in industry, this is very important, being able to talk to people and adapt to different environments. For me, I'm in Korea right now, so I never thought I would move to Korea, but being adaptable is a huge part of why I can work in this environment. Moving to a different country, different language completely. I think if you can show adaptability, then it's highly rated in the business world. Commercial awareness is, I guess, something you can learn and pick up. You can learn and pick up as you are going along in the business. So for me, I'm starting in this startup business, startup company, and a lot of these skills I've learned along the way, just interacting with the business developers and interacting with the finance guys. And going into startup allows you a lot more hands-on opportunities to work things that you never tried in research. You learn about the commercial side of a lot of things, and I don't know, this for me, this is quite interesting, but I like to learn about different things in the industry, but for you, you need to figure out what you want to learn and what you want to do, and then go for those positions and opportunities that might present to you. So I guess in summary, my career has been a lot to do with a bit about luck. A lot of these opportunities were presented to me in a time-wise. It just fell into my lap a lot of these positions, and I had to take the opportunity to when they presented. Pros or cons of academia and industry, I don't think there's much you can, I think, everyone knows the pros of academia is about flexibility and you can do your passion, but in industry, I think, there's might be a bit more financial benefit, but these things are obvious. Yeah, I'll just finish it off with that then.
Thank you very much, Sammy. This is very helpful information for all the students and PhD students. So let's welcome Professor John Gregg to give us the closing remark and announcement of winners of this year's symposium.
Look, Jing, thank you very much. And I'd really like to start by congratulating all the students and their wonderful presentations. It really highlights the vast diversity of work being undertaken at Stateside Institute across all aspects of eye health and vision science. So really a wonderful presentation today from everybody. This is our first online one, and I think everybody managed the technology well. We're so used to Zoom meetings now, but when they drop out, we thought it was a technical issue rather than actually a timing issue. So that was a little sort of jolt at the start, but I think we got used to the timing after that. I'd like to particularly thank the Early Career Working Group who've really done a lot of the background organizing. So Pauline Koo, and then today Jing, who's hosted this. So thank you very much to both of you and to your group. I'd like to thank the SafeSite group of Janet and Emma, who've done a lot of work behind the scenes to make this day work. And so brings me to sort of thanking our judges, so Matt Simonovich, Lise Cornish, and Yasa Razavi, so that they've been working and crunching the numbers behind the scenes, got their abacus out. And so the list that's been presented to me, and hopefully I read this in the right order, is that, so in third place, we'd like to congratulate Dr. Jackie Tan for the presentation on novel infrared laser activated chitosan-based thin film adhesive for sealing full thickness corneal laceration in rabbits. So congratulations to Jackie Tan for third place. So it's hard to have clapping.
Yes.
And then the second place was awarded to Sophia Zagora for her presentation on pediatric uveitic glaucoma and the advent of biologic therapy. So congratulations, Sophia. And then in first place was to Dr. Jed Lufthaus, the effects of open-angle glaucoma on conventional aqueous outflow visualized by hemoglobin video imaging. So congratulations to Jed. So really, I think overall it was a really very high standard of work presented today and across a vast array. And so I'd really like to congratulate everybody who presented today. And again, thank you to Jingjing and Pauline. So it's the one downside is we can't all gather for a drink, but maybe we'll have to do that virtually later on. So thanks everybody for today.